Uused. I'm Associate Professor of Women and Maternal Health Nursing. I feel happy to be with you today in this wonderful conference. I thank the conference organizers and coordinators for their attention for the details and how they help us to be comfort in the conference time and day. Thank you very much. Thank you again, Anhar, for presenting me and moderating this session. Is it clear? Is the screen is clear? My session today is about postpartum depression as a neglected maternal health. We will talk about introduction, type of postpartum depression, the etiology, risk factors, pathophysiology, symptoms, diagnosis, who is at risk, and at the end we will talk about the treatment and management. Childbirth is difficult and exhausting process. A female goes through a lot of hormonal, physical, emotional, and psychological changes throughout pregnancy. Postpartum depression is a serious health issue that can affect about 15% of the female population after giving birth. It often conveys the significant negative consequences to the offspring. In another study, they reported that approximately 10 to 20% of women experience depression, either during pregnancy or in the first 12 months postpartum. Postpartum depression is one type of depression that affects some women after giving birth. The symptoms include irritability, anxiety, sadness, changes in sleeping and eating pattern, and low energy. The incidence of postpartum depression varies widely in different regions and population. Postpartum depression most commonly occurs within 6 weeks after childbirth. It occurs in about 7% to 20% of women. It occurs more commonly in mothers who deliver premature baby and women living in urban areas. African American and Hispanic mothers reported onset of symptoms within 2 weeks of delivery, unlike white mothers who reported onset of symptoms later. The women at risk of postpartum depression are rarely recognized, although it's a well-known clinical phenomenon. Common risk factors of postpartum depression are poor economic, pregnancy-associated complications, low education, unplanned pregnancy, housewife, inadequate social support members, feeding by formula, lack of relationship with family. Inadequate social support from type of delivery, gender of baby, or that baby feeding method of the baby, care of the baby. This is many studies about the risk factors. Another study reported that women with depressive symptoms at the early stage of postpartum period were associated with an increased risk for negative infant feeding outcomes. In the Saudi study showed that more than a quarter of women were likely to have postpartum depression. That means that the mothers needed monitoring, support, health education, diagnostic assessment, and possible treatment by primary health care physician or specialist. Prepartum depression can cause bonding issues with the baby and can contribute to sleeping and feeding problems for the baby. In the longer term, children of mothers with prepartum depression are at greater risk for cognitive, emotional development and verbal deficit and impaired social skills. What are the types of postpartum depression? There are 3 different types of postpartum mood disorders. The first one is the baby blues. Postpartum depression is the second one, and the third one is postpartum psychosis. The baby blues affect between 50 to 75% of women after delivery. If the mother experiencing the baby blues, the symptoms will be frequent, prolonged attack of crying for no apparent reason, sadness and anxiety. The condition usually begins at the first week, 1 to 3 or 4 days after delivery. Although the experience is unpleasant, the condition usually subsides within 2 weeks without treatment. The best thing that the mother can do is find support and ask for help from friends, family, or partner. Postpartum depression is a far more serious condition than the baby blues, affecting about 1 to 7% of new parents. If the mother had postpartum depression before, the risk increased to be 30% for each pregnancy. The mother may experience alerting, high and low, frequent crying, irritability, and fatigue, as well as feeling of guilty, anxiety, and inability to care for her baby. Postpartum psychosis is an extremely severe form of postpartum depression and require emergency medical attention. This condition is relatively rare. The symptoms occur quickly after delivery and are severe, lasting for a few weeks to several months. Postpartum psychosis symptoms include severe agitation, confusion, feeling of hopelessness and shame, insomnia, paranoia, delusion or hallucination, hyperactivity, rapid speech. The risk factors. The number one of risk factors for postpartum depression is undiagnosed depression during pregnancy. There is evidence that a number of risk factors that are associated with maternal depression. Women experiencing these risk factors should be watched carefully by providers and screened regularly during pregnancy and postpartum. Psychological history of depression and anxiety, premenstrual syndrome, negative attitude towards the baby, the baby gender, history of sexual abuse with partner. All of these are factors to develop postpartum depression. There are social factors like lack of social support can cause postpartum depression, domestic violence in the form of both sexual and physical and verbal abuse can also be a cause. Smoking during pregnancy is a risk factor for developing postpartum depression. For the lifestyle risk factor like eating habits, sleep cycle, physical activities, and exercise may affect the postpartum depression. Vitamin B has known to be involved in postpartum depression risk factors, which in turn affect the mood. It's evident that decreased sleep is associated also with postpartum depression. For the pathophysiology, the pathogenesis of postpartum depression is currently unknown, but it has been suggested that genetics, hormonal and psychological factor, social factor, and life stressors play a role in the development of postpartum depression. The rapid change in reproductive hormones like estradiol and progesterone following delivery can be the potential stressor in the susceptible woman, and these changes can lead to the onset of depressive symptoms. Oxytocin and prolactin also play an important role in the pathogenesis of postpartum depression. The symptoms. The warning signs are different for everyone, but may include a loss of pleasure sensation or loss of interest in things the woman used to enjoy, eating much more or much less than usual, anxiety all or most of the time, or panic attack, racing scarcity thoughts, feeling guilty or worthless, fear of not being a good mother, fear of being left alone with the baby, inability to sleep, sleep too much, difficulty to or resting asleep, the baby, hurting the baby or herself. A woman experiencing prepartum depression usually has several of these symptoms, and the symptoms and their severity may change. These symptoms may cause new mothers to feel isolated, guilty, or shamed. Diagnosis of postpartum depression. Women experience postpartum depression usually has several of these symptoms. And the symptoms and their severity may change. These symptoms may cause a new mother to feel isolated, guilty, and shame. In clinical practice and in various studies in the literature, the onset time of postpartum depression has been generalized to be 1 year postpartum. While there is no specific diagnostic test for postpartum depression, it's a real illness and should be taken seriously. Uh, there is a scale, Edinburgh Postnatal Depression Scale is a set of 10 screening questions that can indicate whether a parent has symptoms that are common in women with depression and anxiety during pregnancy in 1 year following birth. Who is at risk? Research suggests that stress hormones and thyroid hormone levels during pregnancy and after delivery have a strong effect on moods and may contribute to postpartum depression. Other factors include physical changes related to pregnancy, change in relationship and at work, worry about parenting, and lack of sleep. Of depression, postpartum depression, or other mood disorder. Women are at increased risk for depression during or after pregnancy if they have previously experienced postpartum depression or any kind of depression. Can postpartum depression be prevented or avoided? Postpartum depression cannot be prevented or avoided. It's recommended to screen for depression in the general adult population. This includes pregnant and postpartum women. For the treatment of depression during pregnancy is essential. Greater awareness and understanding can lead to better outcomes for women and their babies. Postpartum depression is treated much like any other type of depression. Psychological treatment usually happens in the form of counseling or psychotherapy, either one-to-one or with a psychiatrist or in a group setting. Medical treatment for postpartum depression include pharmacotherapy with antidepressant drugs. In fact, antidepressant medication is the most common treatment for postpartum depression. Living with postpartum depression. Feeling depressed doesn't mean that a mother is a bad person. It doesn't mean that the mother did something wrong to the baby or for herself. Or she brought this for herself. Doesn't mean that the mother doesn't love the baby. She should understand this. Many studies have shown that during the screening of selected women, the majority of healthcare facilities don't report this issue. It's our role to report this for the mother. It's not your fault. The disturbances of postpartum depression can range from a 2-week period of mild depression to a period of psychosis, a life-threatening condition for both the mother and the child or her baby. For conclusion, postpartum depression is a serious health issue for new mothers and has negative consequence raises strong public health concerns. Postpartum depression is likely to be influenced by a multitude of risk factors, including biological, psychological, and even environmental factors. This is my reference. Is there any question?
I'm Dr. Michelle Huaykim, a PhD holder in dietetics and nutrition from Florida International University. Actually, I'm an assistant professor in King Faisal University in a clinical nutrition department, and I'm also a vice head of the department. So today I'll present part of my studies that I have done previously among obese children, which is my subspecialty, pediatric nutrition. And I check the effect or evaluate the effect of mother participating in a nutrition intervention education among obese children. The study was conducted in Kuwait. The thing is, for this study, I would like just start with some parts of the introduction. There are many factors that might cause, sorry, I cannot see here. Yes. There are many factors that might cause obesity, as we know: genetics, illness, lifestyle, including the behavior specifically, as well as the culture. And you know that in our Gulf countries, that the cultures has a great role in increasing this issue among the world. And now the obesity start becoming epidemic more than it's a factor or a risk factor of any disease. Several programs involve parents as a fundamental element to change children's behavior and decrease their weight. The evidence shows that parents' engagement is essential for success obesity prevention strategies. Lack of parental engagement as a component of a child intervention would decrease the effectiveness of long-term sustainability. So in my study or in this intervention, I use a social cognitive theory that was assumed that children, if they join their parents and use them as a role model for selecting the healthy meal, performing physical activity, would have a great effect on their behavior positively. Therefore, the parent should participating directly or indirectly in a behavior modification intervention. So the plan in that study was to prevent or preventive intervention engaged not only the children in that camp or the program that I have done, but also with their parents. So the aim of the study was to determine whether the mother's participation in a nutrition education program affects obese children's body weight and health behavior, and also to evaluate the change in attitude toward food, beliefs, the couple of the mother and child together participating in a healthy habit program. That was the program that I intervened there in Kuwait, I mean. So the method was, first, the design of the study. It was developed, as I mentioned before, based on the social cognitive theory to promote the knowledge and behavior changes. The sample was around 41 children in the group or in the intervention. 19 of the children was engaged by supporting their mothers, and the left of the 41, they're only taking the intervention or we're doing the intervention on them. Like both groups having the intervention, but only 19 have their mother support to check the effectiveness of the intervention. So the eligible criteria for the inclusion criteria, children and mothers should consent to enroll of this study. The mother and children should be able to participate in the study for 8 weeks, I mean like 2 months. Children in the summer camp should be willing to attend at least 80% of the nutrition education sessions. For the exclusion criteria: children who suffered from mental disabilities, including autism, ADD, chronic disease required medications, like also diseases require medications like diabetes, cancer, heart disease, hypertension, whatever kind of a disease or chronic disease required medication would be excluded. Also, children who are taking medications, supplements, will be also excluded. So the intervention, so for the all children, I mean the children who were having the intervention, the nutrition education, and the children who have the mother support, will all have sessions or nutritional educational sessions to promote behavioral changes, also with some physical activity offered by the camp. Only 14 mothers of 19 children were educated based on the social cognitive theory construct through WhatsApp messages. The mother also receives material related to the topic covered respectively in the children program, such as food recipe, healthy cooking, list of the healthy snacks that the children could be encouraged to continue their behavior at home. The nutritional educational sessions were actually 8 topics were discussed with the children, including breakfast and how is importance of having a breakfast, healthy snacks, portion size, calories intakes or calories counted, and the nutrition fact that the children could read the nutrition fact behind or at the back of any product they could buy. The data collection tools, I used the socio-demographic questionnaire at the beginning or at the baseline of the study, and the questionnaire that reported parents and children's social status. For also the BMI, it was measured based on the World Health Organization BMI categories for the children. The Healthy Habit questionnaire to measure their food intake and behavior. So children were answered the questionnaire, was designed to evaluate the relationship between the behavior, knowledge, food and health. Also, I asked the children to take a photographic of their food, and it was the novel for the study that year when I conducted the intervention. It was in the first study using this type of tool because I was like, need to make sure that the children giving me the right information about their food. So I asked them to take a photograph, or I took a picture of their food before and after their meal, or after they ate their meals, by using their iPad, iPod, or iPhone. As we know, this generation using the technology that much. So I use this way to make sure or to collect their food intake. I also had a 24-hour recall with the children, interviewed them twice to assess their food intake at home and confirm the accuracy of the tool that I use. With these methods, we were able to measure children's energy consumption and type of food with the portion size too. For the maternal data, actually, I provide the mother's general nutritional knowledge and behavior questionnaire, which aim to assess their mother knowledge or the mother's knowledge, behaviors, and their influence their respective on their respective the children eating behavior. So the results of the study, speaking about the general characteristic, the 2 groups, I mean the healthy habit group and the healthy habit group with mother support, there were no significant differences between the 2 groups. This is what we want to compare them. Also, there was only one significant difference in their BMI. So the children who were in a group of the mother support were more obese than the children in the healthy habit program. And it was significant difference between the two group of having obese children. So the children with the mother support were more obese than children having only the program, with the p-value 0.006. Regarding to the body weight and behavior changes, as we can see the differences here between the two groups, the healthy happy groups and the maternal supported group, there were significant differences in a weight loss with the p-value, since they started the baseline till the 8 weeks, we can see the significant difference between the two groups. Also, there was a more significant between the in the maternal group, the maternal supported group, there was a significant p-value in a weight change with the p-value 0.14. Also, for the breakfast meal, if the children had the breakfast meal, we can see here in the maternal supported group that the children who have maternal support group were significantly increasing their breakfast meal more than the other group. Also, the calories intake, we can see here also that both groups have significant difference between the baseline and 8 weeks. And speaking about the maternal support group, had a great significant with the calories at the baseline, where they were actually 2,140, and at the end of the program were 1,759. Speaking about the body between the both test and and to check the differences between the two groups, actually we use the independent t-test, as you see here, to compare the differences between the two groups. And there were the children who had the maternal support had significantly decreased more weight with the p-value 0.048. And you can see here in this diagram how it shows that the children with the healthy habit program only decreased their weight significantly, but comparing with the maternal support, there were more decreasing in their body weights. Now moving to the attitude and behavior, we see here in this table the self-efficacy changes between the baseline and 8 weeks of the both group. Here in the top, we see the difference of the healthy happy group at the baseline and 8 weeks. We see the changes of choosing a healthy snacks at the beginning of the program. Only 40% of the children had select the healthy snacks. However, at the end, 95 of them chose a healthy snacks. For the maternal support, with the maternal support, actually, there were only 21% of the children selecting a healthy snacks. At the end, all the group, the 19 participants selecting the healthy snacks. Speaking about the changing in the portion size, we see the children, the maternal support, where at the beginning, only 50% who decreased the portion size. However, when we compare it with this children with the maternal supports, 74 of them choosing a healthy or decreasing their portion size with the p-value 0.001. For this table, as we see regarding to the attitude, it changes. I asked the children how sure they could choose a healthy snacks, and we see, or comparing, once we compare the baseline with the end, 8 weeks, we see the children in the maternal support here, 18% were very sure that they can have a healthy snacks. However, at the end, 82% were able or were sure that they can have their healthy snacks. Comparing the two groups together, we see here a significant p-value with the 0.001 children able to choose a healthy snacks who were having a maternal support comparing with the healthy habits program only. Also, when I asked them how sure they could eat a breakfast every morning, so only 11% of them with the maternal support at the beginning or at the baseline, 58% of them were able or were sure to have the breakfast. However, at the end, 82% of them able to choose it, and that was significant comparing the baseline with the 8 weeks end. And when we compare the both groups together, we see that was significant. Actually, I used the chi-square test, and it was significant improving among the children with the maternal support more than the children only having a healthy habit group. Regarding to the mother's attitude, as you can see in this table, I use the McNemer test, Perty test, and the chi-square test. For the McNemer test to compare the efficacy, self-efficacy at the baseline and 8 weeks, we can see the mothers who were able to choose the healthy snacks were only 16%. However, at the end of the program, they become 95%. Also, for the breakfast was significant differences between the baseline and 8 weeks. And it showed that the mother who were participating in the program has significantly improved their food intake or the breakfast intake, and that was significantly with the p-value 0.001. Asking the mothers about how sure they are able to have their breakfast. So at the beginning, we're only for 21%, at the end, 58% improvement with the p-value 0.39%. For the discussion, the current study or the study was designed based, as I mentioned, the theoretical model, the social cognitive theory, to see the impacts of the mother or to check or assess the impacts of the mother involvement for improving their children eating behavior. Our analysis supported the hypothesis, as I mentioned, that their mothers have the support. The children with the maternal support changed their weight eating behaviors beyond the effect of the 8-week camps and nutritional education. Children with the maternal support decreased their body weight, skipping breakfast, less consumed of the calories, less calories compared with the baseline behavior and the other children in the camps intervention without maternal support. Therefore, our hypothesis was accepted. After the 8 weeks healthy habit intervention program in the camp, both group with or without maternal support consumed breakfast more, chose more healthy snacks, reduced the portion size, decreased the caloric intake significantly in an intergroup analysis. However, the intergroup analysis showed that the group with the maternal support improved their eating behaviors and attitude significantly more than the group without maternal support. Like what I meant is both the group has improvement or had improved. However, with the maternal support had a great positively results. For the conclusion, the outcomes of this study showed that maternal support and their involvement with the nutrition education, their children contributed to more positive changes in eating behavior, attitudes compared with other children healthy habits program without maternal involvement. So maternal participation, as I mentioned, the introduction influenced their children without influenced their children weight and behavior. So thank you all for listening for this presentation.
Thank you. King Faisal University, and I am a nurse educator in the Mam Health Networking. I'm working for 10 years. And my topic is presented for you is just something like in my field. Like, it's interesting. I hope that you will enjoy my class, which is about improving the effectiveness of nurses teaching and learning methods using Kirkpatrick model. So basically, first, I'll just introduce a little bit in the field of nursing education. Continuous improvement in teaching and learning methods is crucial for ensuring the highest quality of patient care. As a healthcare practices involve, nurses must be provided with the most updated knowledge and skills to meet the changing demands of profession. To achieve this, educators and institutions need to update their strategies that enhance learning process. One model that can guide improvement of nursing education is Kirkpatrick model, which evaluates training program based on 4 levels: reactions, learning, behavior, and results. By applying this model, nurses can assess the effectiveness of their teaching methods and make necessary adjustment to enhance learning outcomes. The objectives of this presentation by twofold. Firstly, it will be like to discuss the importance of continuous improvement in nursing education and its impact on patient care. Secondly, to explore how Kirkpatrick model can be utilized to evaluate and enhance the effectiveness of teaching and learning methods in nursing education. By focusing on these objectives, we aim to empower educators to create dynamic learning environments that maximize the potential of nurses and improve the healthcare outcomes. So the challenges that the teaching and learning methods in nursing education face various of challenges that hinder their effectiveness. So one significant challenge that which is diverse learning styles and preferences among nursing students. So translation lecture based approaches may not cater to the individual needs of the students, leading to suboptimal learning outcomes. Additionally, limited resources and time constraint can restrict educators from implementing innovative teaching strategies that promote active engagement and critical thinking. To address these challenges, comprehensive framework is essential to assess and improve the teaching and learning methods. The Kirkpatrick model offers structure approach by evaluating the training programs, as we said, on multiple levels. So it enables educators to assess the learners' reactions to teaching methods, measuring their knowledge acquisition and the retention. So, and observe the transition of knowledge into clinical practice and assess the impact on the patient's outcome. So by adopting this technique or the model, the nurse educator can gain a valuable insight into the effectiveness of these teaching styles and can make data-driven improvements. Here, the model. So the Kirkpatrick model is widely, as we said, is the framework that we can use for evaluating the training program. So firstly, we go through the reactions, the level assessing the participants' immediate response to training, measuring their satisfaction and engagement. The learning level evaluates knowledge acquisition and understanding. Then the third one, which is the behavior level, this examines the application of learned skill in practice. The fourth one will be the results level focus on overall impacts, such as improve in the patient outcomes. So these models can be applied to evaluate teaching and learning effectiveness by systematically assessing the participants or like students' reactions, knowledge acquisitions, and application of skills, and the resulting outcomes. It helps educators identify strength areas for improvement and make data-driven judgment to enhance the effectiveness of their teaching methods, ultimately improving the quality of nursing education. So the first one, which is the first level, which is assessing the initial reaction of nurses and the students to teaching and learning methods is crucial, as we said, for several reasons. So the first one is to provide valuable feedback on the effectiveness of instructional approach. By understanding the participants' reaction, educators can identify what aspects of teaching methods are engaging, motivating, and relevant to them. This feedback enables educators to tailor their approach to better meet the learner needs and preferences. Secondly, participants or students' perceptions and engagement significantly impact the learning process. So the positive reactions such as enthusiasm, interest, and satisfaction create a conducive learning environment. When learners perceive the teaching methods as valuable and engaging, they are more likely to actively participate, retain the information, and apply in their practice. Conversely, when it will be the negative reactions or disengagement can hinder the learning outcomes and will cause like unfavorable results or diminish the knowledge that needed to be retained. So by assessing initial reaction, educator can gain insight into the participants' motivation, expectation, and learning preferences, as we said. So, well, the second one is about the learning levels in Kirkpatrick evaluates the acquisition of knowledge and skills by participants. Okay, so it assesses whether the learner have gained new information, improved their understanding, and developed competence or have competency in doing such practice in applying what they have learned. This evaluation can be done through various methods such as tests, quizzes, scenarios, case studies, simulation, to measure the extent of knowledge acquisition and the ability to apply this knowledge into practice. So effective instructional strategy and curriculum design play a crucial role in promoting positive learning outcomes, engaging and interactive learning methods, such as problem-solving activities, group discussions, hand-on exercise like demonstrations, as we said, so and real-life simulation can enhance learners' understanding and retain their knowledge. Well-designed curriculum that align with learning objectives and incorporate relevant and current content also contribute to successful learning outcomes by employing their effective instructional strategies and design a comprehensive curriculum. Educator can facilitate the acquisitions of the knowledge and the skills leading to improve the learner outcomes and the learning outcomes. So assessing behavioral changing resulting from educational program. Okay. Assessing behavioral change resulting from educational program is significant because it indicates the successful transfer of knowledge into practice. It evaluates whether nurses can effectively apply the newly acquired knowledge and skills in their professional roles by observing changes in their practice, in their behavior and performance. Educator can judge the effectiveness of the educational program or the course that and what you have to do is in promoting real-world application for these skills. So to transfer newly acquired knowledge into professional practice, nurses can employ several strategies. First, they can engage in reflective practice like this. So critical analysis can be about their experience and identifying opportunities to apply new knowledge. Additionally, nurses can collaborate with the colleagues, their classmates and mentors, seek peer reviews also can be, so seeking guidance and feedback to ensure proper implementation. Implementing evidence-based practice guidelines and staying updated with the current research and evidence also facilitate the integration of a new knowledge into practice. Furthermore, creating supportive work into practice. Creating a supportive work environment that encourage continuous learning and provide resources for professional development enhances the likelihood of successful knowledge transfer. For the results, evaluating the impacts of teaching and learning methods has to be there and for the patient care, no? So on patient care and the outcomes is crucially to ensure what if this effective teaching program approached, the elements approached. The ultimately goal of education is to enhance patient outcome and improve the quality of care. By assessing this impact, educator can determine whether the educational program has translated into tangible improvement in patient care. Is it already reflected like that? So the result level of Kirkpatrick provide insight into overall effectiveness of educational program. By measuring the achieved outcomes, it assists factors such as enhanced patient safety, improved clinical outcomes, make and measured the satisfactions and better healthcare delivery. These results demonstrate the direct impact on educational program and patient care and validate the effectiveness of teaching methods already employed or already implemented. By evaluating the impact on patient care and outcomes, educators can identify areas of success and areas of where it need to be improved. This information inform the future curriculum or the program development, instructional strategies, and educational intervention, leading to continuous enhancement in nursing education. So from the Kirkpatrick model that can be applied to assess the teaching and learning. So the first by the evaluating each level in the model, the reaction, this level can be assessed through what? Through survey, feedback forms, or interview together the participants' perceptions of teaching and learning methods, their satisfaction, engagement, and perceived relevant of the content. So while the learning, knowledge acquisition and understanding can be evaluated through the test, quizzes, assignments, or performance assessments to measure the extent to which learners have gained new information and improved their skills. By this, how about the behavior and the attitude, the application of this knowledge and the skills that already applied into the patient's bedside or into the class seminars, assist through observation, checklist that you have it about the simulation or case study seminars to determine if the learner already approached the criteria and able to transfer the knowledge into the clinical setting, demonstrate appropriate behavior and practice. So the result later on will impact, and the impact like into the patient care. The outcome can be evaluated by analyzing the patient report, measuring the healthcare metric, or conducting survey, like to assess the survey, to assess the improvement and the patient safety. Clinical outcomes, patient satisfactions, are overall quality of care, like we are saying in we are having the KPIs in the hospital so that it can be assess the patient's outcome. So using Kirkpatrick model and nursing education offer several benefits. Firstly, we said that structured, it will provide a structured framework to evaluate the teaching methods and ensuring comprehensive assessment. This allowed to gather the variable insight of this effective teaching and practice, and assessing the assessment conducted through a model provided educator with the data driven with the evidence feedback that can be measured. This inform and guide for decision making and improve the educational practice by identifying strengths and the weaknesses at each level of the model, and also judge such as modifying the structure or the strategies or the curriculum design. So this is the ultimately the applications of Kirkpatrick model has potential to enhance patient outcome in nursing care by evaluating the impacts of educational program on patient care and outcome. Educator can identify the gap and then can bridge the theory into the practice. So, and this is how to promote the evidence-based practice into the care. This process facilitates the integration and updated the knowledge, as we said, into the practice itself, resulting in improving the quality of the care and satisfaction to the patient outcome. And we have the examples here for each one to apply the Kirkpatrick models in nursing education, like the reaction. Nursing students complete the post-test survey. So this one providing feedback on effective and relevant of new simulation-based learning model. Their positive reaction in that survey indicate high engagement and satisfaction with the interactive learning experience, what they learned, okay, what they got. Learning, now this is the level of the learning. So the pre and the post tests are conducted to assess the knowledge acquisition of nurses attending a continuing educational workshop. This is an example on infection control. So the result increase in courses like where there is improvement, indicate successful training outcomes. Also, there's other measures, but this is an example also here. So the behavior now, go through like clinical instructors observe with their checklist, with their evidence guide criteria, and evaluate the application of newly acquired skills by using students, by nursing students during, clinical instructor observe and of the skill through this list by nurse student, during the patient scenarios, their ability to demonstrate appropriate technique and adherence to protocol reflects the effectiveness transfer of this knowledge into the practice. The results, study evaluate the impacts of evidence-based practice course on nursing staff, patient outcome, such as reducing medication error, for example, or to see the satisfaction of such a problem, or documents improvement and improving the infection control. This demonstrates the positive impact of educational program on healthcare qualities or healthcare quality. So using Kirkpatrick model for continuous improvement in teaching and learning methods, open opportunities future for implication direction for nursing education can be. One direction is integrating the technology, the data analysis to enhance the assessment and the feedback collection at each level. This could involve using online survey, learning management system, and performance analysis to gain deeper insight into learner reactions, knowledge acquisition, behavior change, and patient outcome. Furthermore, ongoing evaluation and adoption of educational program are crucial to stay current with the advancements in healthcare system and educational programs, or regular assessment of teaching styles and the methods allow the educator to identify areas of for any need improvement or any lack of or weakness in the program or the courses. This include updating curriculum content, incorporating with structural strategies, and integration evidence-based practice. By embracing ongoing evaluation and adapting nursing education can stay representative to evolving needs and deliver the highest quality education, leading to a better prepared nurses and improve patients' care outcomes. So by the end, in summary of this presentation, emphasizing the importance to improve the teaching and learning methods in this in nursing education. The challenges the challenges faced in nursing education indicate diverse learning styles, limited resources, and the time constraint. So like a model like Kirkpatrick provide a comprehensive framework to assess and enhance this these methods. The models consist of 4 levels, as we mentioned: reactions, learning, behavior, and results. Each level evaluates different aspects of the educational program, from initial participants' reaction to the impact into the patient's outcome or to the organization. It can be also, this model can be applied into further, so to the organization outcomes and such. By using this model, educator in our field can gather the data and insight that can improve their program, their design, their courses, their methods. Ultimately, applying this method can have a potential enhancement into the outcome and promoting the evidence-based practice and continuous improving in nursing education. So I can close my presentation. We remember the words of William Alter when he said, Arthur, said that the medical teacher tell the good teacher explain the superior learning methods and updated methods. You can utilize like this model now. So what I presented, we have opportunity to become those great teachers and educators in our whatever, like we are in our facility, your healthcare system, and into the practice near to the patients. So, and get inspiring the new generation of nurses and improve the healthcare outcome for all. Anybody have any questions? So feel free to ask, and thank you. So like about if you have questions about the Kirkpatrick or have scenarios that we can improve the discussion of this presentation.
Thank you very much, Miss Hamida, for this wonderful
involve using the most conveniently available people as a participant. Regarding the setting, the study was conducting from July 2090 to September 2090 in the Affirm Dialysis Center under the Ministry of Health in Al-Confida province.
Dr. Fatima, it is still in the methodology slide. So click on the next slide.
Arabia. There are 2 dialysis centers in Al-Confida province caring for 155 patients. Both centers, which operate within the same system and policy, and both provide care for 6 days per week. Regarding the sample size, now it's moving.
Yes, doctor.
Okay. The total number of patients receiving hemodialysis at the Affirm Kidney Center in Al-Confida was 155 according to data obtained from administrative department of the center. The sample size were estimated by Rosoft equation, and the sufficient number was 111. We found a high number of patients qualifying the inclusion criteria and involved in the study. Therefore, 129 hemodialysis patients were invited and agreed to participate in this study. 15 patients were first recruited for pilot study, and their data were not included in the main study. Therefore, a total of 114 patients were involved in the main study. Regarding the inclusion and exclusion criteria, the inclusion criteria, people who diagnosed with chronic kidney disease and receiving maintenance dialysis, the adult age from 18 years and or older, and who could communicate in Arabic and willing to participate. The exclusion criteria, the pediatrics patients and who have any history of illness that prevent the understanding or responding to the questionnaire. Regarding the instrument, we use the self-developed structure questionnaire with closed-ended and rating questions for data collection, divided into 3 sections. The first section was socio-demographic and clinical sheet, which is include such as gender, age, nationality, marital status, educational leave, and monthly income. The other part for socio-demographic and clinical data, part B, clinical data, which is include dialysis-related variable like number of years receiving dialysis, primary cause of kidney failure, number of dialysis sessions per week, and number of hours per session. The second part of the questionnaires was the kidney disease and quality of life survey, which is evaluation the quality of life, and the instrument was divided into the 36 self-report items, included physical component and mental component summary, the burden of kidney disease subscale, the symptom and problem subscale, and the effect of kidney disease on daily life subscales with 8 items. The third section of the questionnaire was the hospital anxiety and depression scale. This also the self-reported questionnaire. It's divided to 14 items. 7 will evaluation the anxiety and 7 will evaluation the depression. The researcher conducted coordinator with the head of the Affirm Kidney Center to determine the strategy and to inform the hemodialysis patient about the study and identify the eligible participant. The study include every patient meeting the inclusion criteria, and the purpose of a study was explained verbally and written to the eligible participant. The explanation include collecting data from their medical record. After patient agreed to participate, a consent form was signed and study instruments were provided to the participant before the hemodialysis session, as some agreed in the past research. The questionnaires took approximately 15 to 13 minutes for completing. The research waited until the participant had finished the research review each collected questionnaire to ensure no missing data. Some participants were illiterate, so the researcher assisted them in completing the questionnaire. Also, other data were collected by the researcher through reviewing each participant medical record to obtain the medical data. Moving to the research or study finding, regarding the socio-demographic data, as we see, slightly more participants were in the middle age group, and most of the participants were female. And more than half of the patients were married, and most of them were living with their family. Regarding the clinical characteristic of patients, more than 1/3 of patients have the duration of dialysis from 1 to 4 years. The majority of the patients had 3 dialysis sessions per week. Then regarding the quality of life among hemodialysis, this table shows each dimension of quality of life and total of kidney disease quality of life was 14.9. Among the 5 quality of life domains, the highest domain score reported in symptom problem list and affect kidney disease, and the lowest score were found in burden of kidney disease and physical function. Here also we test the prevalence of anxiety and depression among the participants. We found 15% of participants had anxiety and 45% had a depression percent. Hemodialysis patient. This figure shows the correlation between depression and anxiety. There is a positive, strong correlation was detected between these two symptoms. Also, we test the association between anxiety and depression among quality of life hemodialysis patients. The Pearson correlation coefficient test used to assess the correlation between anxiety and depression among quality of life. It revealed that there was inverse correlation between anxiety and quality of life and between depression and quality of life. Regarding the association between quality of life score among anxiety and depression symptom, the results showed that the higher total quality of life score is significantly associated with depression and anxiety. When comparing the main score of quality of life domains among patients with or without presence of anxiety and depression, we found that the main score of quality of life in each domain in each domain was significantly lower among patients with anxiety and depression. In addition, the burden of disease and physical component score were shown to be associated with poor quality of life, and they were mostly affected by both anxiety and depression. Regarding the correlation between the kidney disease quality of life domains versus the anxiety and depression scale among hemodialysis patients, we found the results showed that anxiety and depression were significantly correlated with each domains of quality of life, and there was negative moderate correlation between these symptoms and each quality of life domains. Also, the linear regression was conducted to test the prediction of depression and anxiety on quality of life. Depression had more impact on the quality of life domains than had the anxiety. The study also tests the relationship between the sample characteristic, quality of life, anxiety, and depression among hemodialysis patients. As shown here, anxiety and depression and quality of life differ significantly according to the sample characteristic. When comparing the association between them, we found that elderly group and female group and illiterate participants were more associated with poor quality of life, along with anxiety and depression. Also, the dialysis duration of 5 years or more was significantly associated with a low quality of life, but did not differ in terms of anxiety and depression. Based on the finding, a significant inverse relationship was discovered between our symptoms, psychological symptoms that mean anxiety and depression, and quality of life. The quality of life among our test group was deemed low, while depression and anxiety were found to be highly prevalent. Considering the increasing global prevalence of using hemodialysis therapy and its important mental health well-being among patients with chronic kidney disease, frequent assessment of psychological condition and their effect on individual quality of life are vital. Anxiety and depression are more common symptoms among patients undergoing hemodialysis. For that, we have conduct research or studies regarding this topic. Early detection and treatment of anxiety and depression may have a positive impact on disease outcome. Healthcare providers, especially the nurses who perform dialysis, should assess all patients for anxiety and depression regularly in conjunction with assessment of quality of life with routine care. It is necessary to improve the diagnosis process and screening measure for those symptoms to detect this efficiently. Applying a psychological intervention program for dialysis patients is needed, such as health education and cognitive behavioral therapy intervention as studies. Nurses in nephrology department should provide adequate information for patients about anxiety and depression symptoms so as to enhance coping strategies. This is our reference, our article. Any question? Thanks for listening.
Thank you very much, Ms. Fatima. Do you have any question?
Nurse educator and faculty member from Najran University. The outline of my presentation, move to next, please. Move. The table of content, first one, introduction, basic concept is the route towards becoming, towards a role model, becoming, core competences for nurse education or educators. Introduction. Next. And care of physically ill, mentally ill, and disabled people of all ages in all healthcare and other community settings. Next, the unique function of nurses in caring for individuals sick or well is to assess their responses to their health status and to assist them in the performance of these activities, contributing to health or recovery or to dignified death that they would perform unaided if they had the necessary strength, will, or knowledge, and to do this in such way as to help them gain full partial independence as rapidly as possible. Basic concept is caring in nursing is a special way of being, knowing, and doing with the goal of protection, enhancement, and preservation of human dignity. Applied to daily nursing practice, caring is action and competences that aim toward the good and welfare of others. Role modeling is the practice for admiring an individual's behavior or attitude, then adopting that behavior or attitude. In nursing settings, role modeling is a crucial due to the prevalence of a professional behavior. Ethics is a system dealing with the standards of character and behavior related to what is the right or what is the wrong. Professional behaviors are those that reflect the nurse's commitment to secure the interests and welfare of those entrusted to the nurse's care. These behaviors follow out of the professional values of nursing as identified by the American Association of Colleges of Nursing, like autonomy, human dignity, integrity, and social justice. The route toward becoming a role model, nurse educators are responsible for setting up modeling as foundational element in the education of prospective nurses. In order to prepare nurses to be leaders and role models in the field, nurse educators need to teach in a way that allows students to feel comfortable or more comfortable within the workplace environment. There is 5 categories for successful role modeling based on qualitative research. First one, influencing others, developing dimensions among students, situational self-awareness, constructive feedback, and continuous effort. There is core competences for nurse educators in clinical areas. First one, facilitate learning, facilitate learner development and socialization, use assessment and evaluation strategies, and participate in curriculum design and evaluation. The facilitate learning serve as a positive role model of professional nursing by accepting characteristics such as being empathetic, supportive, non-judgmental, calm, and approachable. Demonstrate a passion for teaching, learning, and the field of nursing to inspire and motivate the learners. Also, the clinical experience should give the learners opportunities to apply the content they learned in the classroom and also performance skills practiced in the laboratory. Initial experiences should involve basic care, such as bathing, ambulating, and then progresses to more complex skills such as suctioning, wound care, also intravenous therapy. Ask the learners questions about what? About the care they are giving and the expected the results of patient treatment. Implement varied clinical teaching models. Second one, facilitate learner development and socialization. Is provide a learning environment that fosters cognitive, psychomotor, and affective learning. Promote professional integrity, accountability, and emphasize maintaining respect and dignity for all. Help students to engage in self-reflection process that helps them to identify their goals and the limitations and establish ways to improve their practice. Facilitate learners' development and socialization, foster professional growth of learners through coaching, simulation, experiences, and debriefing. Maintain professional boundaries and engage learners in applying best practices. Plan appropriate clinical learning activities to promote clinical decision-making and teamwork. Also, apply ethical and legal principles to ensure a safe learning environment. Create an environment that focuses on preparing learners for their future roles. Also, familiarize learners with various cultural beliefs that could impact the way they deliver by nursing care. Identify learners who are not adjusting well to their role as a future nurse and advise and counsel them as necessary. Use assessment and evaluation strategies. Use a variety of strategies to assess and evaluate the learners. How? By ability to meet course outcomes, and this data also should be used to enhance the teaching by teaching on and learning process. Provide timely, constructive, objective, and fair written feedback to learners. Also be precise and specific when providing constructive criteria. Should be by identify the specific areas of strengths and weaknesses. Maintain timely communication with course faculty regarding learner performance and progression. Participate in curriculum design and evaluation. Nurse educators can contribute to curriculum development and program evaluation based on their current practice. A practicum in clinical setting keeps on up to date on current healthcare delivery trends, as well as with the rules and responsibilities of nurses working with constantly changing environment. Bridging the gap between theory and practice. How? By clinical nurse educators are needed to facilitate the development of clinical skills and the application of knowledge to practice for nursing students. Clinical nurse educators are also challenged to assist students with the development of clinical decision-making skills. Along with decision-making skills, students need to be socialized into the role of the professional nurse. The most challenge of these skills to teach is that of clinical decision-making when the pertains to real-life patient situations. Acting as a role model in assisting a student to development into competent graduate nurses who can adapt to the practice setting. The clinical nurse educators plays a vital part in role modeling the attributes of the professional nurses. Although the act of the role modeling is often unconscious, the educators must be cognizant that students are watching at all times. The clinical nurse educators must ensure that professional behavior is always being exhibited to avoid role modeling poor behaviors. Acting as a role modeling, it's during 6 process or 6 steps. First one, approachable, ability to instill confidence, available and timely feedback, student advocate, tolerate student mistakes, and demonstrate respect for students. Applying so the slide not clear. Wait, just applying ethical and legal principles when planning clinical legal experiences, assessing learners' abilities, adhering to policies, and promoting learners' compliance. Assessing learners' abilities is the clinical nurse educator assess student learners' abilities to and needs barrier to CLES and informs the students of applicable clinical policies and standards. Clinical nurse educators should assist the student in preparation for the clinical experiences. A preclinical orientation day is a practical way to assess student preparedness for the clinical experiences. If it's determined that the student is unprepared, the student shouldn't be assigned to patient for care activities. A preclinical and post-clinical conferences afford student and clinical nurse educators an opportunity to address student questions and discuss challenging patient care assignments in safe learning environments. Adhering to policies. Because of their subjectively, students often challenge clinical evaluation. It's crucial that clinical faculty understand the student's right to due process. In very general terms, the right to due process, it's equal for term the fairness. In education, the nursing program or college satisfy this right by stipulating in writing the policies and procedures expected in student performance. Promoting learner compliance. In education, the nursing program or college must stipulate in writing in the form of policies what the procedural safeguards and guidelines are and how issues of academic misconduct or performance will be treated. Such procedural guidelines should be ensured that students are given the opportunities to be heard, review the charges and evidence against them, appear before an impartial decision maker, and appeal the decision. Sorry. Demonstrate ethical behavior. Students and faculty reflect the image of the educational institution, a breach of expected conduct, whether covert or overt. reflect poorly on the nursing program and can يعني, place their situation in a precarious predicament. Standards for theory, clinical objectives, and performance must be provided to students at the start of each semester. Student practice expectations should be addressed in the course syllabus or also in the handbook to include. Respectful behavior, communication, and clinical preparation, as well as professional responsibilities to faculty, professional nursing staff, also in for clinical employees or for patients and for also for families. That's it. You have any question? Sorry for technical issue. Thank you
very
for
much,
thank you.
Miss Aisha.
Thank you.
Actually, it's very interesting topic and explanation.
We will talk about introduction and etiology, epidemiology, and management. Next. Introduction. The most important concern for most women during pregnancy is their baby's health. The health of moms is also important during or after pregnancy. Certain medical concerns can put the mom's health at risk. Among these conditions is the postpartum cardiomyopathy, which affects the heart muscle and increases the risk of heart disease. Next. Postpartum cardiomyopathy, also known as prepartum cardiomyopathy, is defined as a new honest heart failure between the last month of pregnancy and 5 months post-delivery with no determinable cause. Postpartum cardiomyopathy is a rare case of heart failure. Next. Its incidence and preference are highly variable depending on the race and geographic regions. Its clinical outcome is also differs from complete recovery to death. Postpartum cardiomyopathy is a diagnosis of exclusion. Postpartum cardiomyopathy is a rare form of congestive heart failure of unknown etiology. Heart failure is prepartum period was discovered in 1849. Its incidence and highly variable depending on the race and geographical regions. Its clinical outcome also differs from complete recovery to death. Postpartum cardiomyopathy is a diagnosis of exclusion. Next. Prepartum cardiomyopathy is uncommon but serious medical condition that affects the woman throughout the world, while the underlying pathophysiology remains unclear. Hormonal influences and genetic susceptibility probably play a role. Etiology. The underlying cause is unclear and likely involves several factors. Research suggests that postpartum cardiomyopathy may be triggered by prior viral illness, nutritional deficiency, hemodynamic stress during pregnancy, or an abnormal immune response. These causes have not been proven. More recent research suggested that postpartum cardiomyopathy may be caused by the overactivity of the certain hormones that cause the damage to the vascular system. These hormones levels have been found to be higher in the women with preeclampsia, which could help explain why they are at higher risk of developing postpartum cardiomyopathy. The exact mechanism of the disease is unknown. However, different hypotheses have been described regarding its etiology: comparison, viral myocarditis, nutritional deficiencies, autoimmunity, hemodynamic stress, vascular dysfunctions, and hormonal insults, and underlying genetics. Epidemiology. The nationwide population-based study showed that incidence of 10.3 patients per 10,000 live births. The incidence increased with age, with a maximum incidence of 40 to 54 years. This incidence is highest in African Americans. The disease is more prevalent in Asia and Africa. History and physical. Most patients present soon after delivery, especially in the first week postpartum. The symptoms are suggestive of heart failure, for example, orthopnea, and the paroxysmal nocturnal dyspnea. These symptoms are usually attributed to normal pregnancy, and this is why the diagnosis of postpartum cardiomyopathy can be easily missed. Physical examination findings include tachycardia, elevated jugular venous pressure, bilateral pulmonary crackles due to pulmonary edema, third heart sound, and displaced apical pulse. Severe cases may present with acute respiratory failure or cardiogenic shock and need for close monitoring in intensive care units. Some of the most common risk factors that development of the postpartum cardiomyopathy are as follows: advanced maternal age, more cases reported in both extremes of age, high palliative, 71% of women diagnosed with postpartum cardiomyopathy had 3 or more perio pregnancies. High gravidity, twin pregnancy, more endemic in women with the twin pregnancy. Also, another factors, use of tocolytic therapy greater than 4 weeks can cause silent ischemia. African descent, cocaine abuse. Next. Symptoms of the condition include shortness of breath, with activity and when lying flat, swollen in ankle and or feet, and cough, chest pain or tightness. Less common symptoms may include feeling of heart racing or skipping beats, palpitations, fatigue, increase nighttime urination, or lightheadedness, especially when standing up. Next. And the New York Heart Association system classifies the severity of the symptoms in patients with postpartum cardiomyopathy. Class 1 disease with no symptoms. Class 2 mild symptoms affect on function or symptoms only with extreme exertion. Class 3 symptoms with minimal exertion. Class 4 symptoms at rest. Next. Next. What does the term ejection fraction means? What does it measure? Ejection fraction is a measurement of the percentage of the blood leaving the heart each time it squeezes. When the heart squeeze, it's called contractions. Ejection fraction is just one of many tests that your healthcare provider may use to see how your heart works. The heart contracts and relaxes. When the heart contracts, it pumps out, ejects blood from the two lower heart chambers called ventricles. When the heart relaxes, the ventricles refill the blood with the blood. Next. No matter how forceful the contractions, the heart can never pump all the blood out the ventricle. The term ejection fraction is the amount of blood as percentage that pumps out of the filled ventricle with each heartbeat. The ejection fraction is usually measured only in the left ventricle. Next. According to American Heart Association, a left ventricle ejection fraction of about 50 to 70 is categorized as a normal. Immediately reduced left ejection fraction is usually between 40. Immediately reduced left ventricle ejection fraction is usually between 41% and 49%. A reduced left ventricle ejection fraction is usually 40 or less. Next. Postpartum cardiomyopathy is diagnosed when meet some criteria. First one, heart failure develops in the last month of pregnancy or within months following delivery. Heart pumping is reduced with the left ventricle ejection fraction of less than 45%, typically measured by an echocardiogram. A normal left ventricle ejection fraction is between 50% and 70%. No other cause for heart failure can be found. Next. Laboratory tests are a standard part of the evaluation. This includes the test to assess kidney electrolytes and liver, thyroid function, and complete blood count to look for the anemia or evidence of infection. Brain nucleotic peptide (BNP) and in terminal pro-NP levels will be significantly elevated in postpartum cardiomyopathy and are used as a heart failure indications. Markers of cardiac injury and stress can also assess level of risk. Next. How can postpartum cardiomyopathy manage? The treatment and management. The treatment is usually supportive and directed toward the management of heart failure symptoms. A standard heart failure therapy is used to optimize the patient's volume status. Next. The goal of postpartum cardiomyopathy treatment is to improve heart function and keep extra fluid from collection in the lungs or other parts of the body. With medical therapy, many women with postpartum cardiomyopathy recover normal heart function within the first 3 to 6 months of treatment. Next. A small number of patients with postpartum cardiomyopathy will develop severe heart failure requiring mechanical heart pumps or heart transplants. Next. Prognosis. Long-term outcomes are variable. 50% of the patients improve with the standard medical treatment. However, 25% of patients develop chronic heart failure and reminder dies during the course of the disease. Next. Diversional diagnosis. Normal physiological effects of pregnancy, severe preeclampsia or eclampsia, pulmonary embolism, previously and diagnosis of valvular disease. Example, rheumatic valve disease, acute pulmonary edema from prolonged tachylysis or preeclampsia, cardiac dysfunction secondary to ischemia or stress, and cardiomyopathy. Next. Cardiac dysfunction secondary to arrhythmia, amniotic fluid embolism syndrome, asthma, and pneumonia. Next. How can women minimize the risk? To develop and maintain the strong heart, women should avoid cigarettes and alcohol and eat well-balanced diet. Women who develop prepartum cardiomyopathy are at high risk of developing the same condition with the future pregnancies. The healthcare professional may discuss contraception with you in order to avoid unintended pregnancy. Next. possible communication include cardiac arrhythmias, can be delayed, congestive heart failure, clot formation in the heart, which can embolize travel from other parts of the body. Next. Conclusion, women who develop prepartum cardiomyopathy are at high risk of developing the same problem with the future pregnancy. The rate of the recurrence is about 30%. Therefore, women who had this condition should be under observation. Next. That's all. Thanks for your listening. And if you have any question.
Enhance its value. I hope you have a fruitful and enjoyable experience throughout the event. Thank you for you all. My name is Dr. Aisha Al-Mafarfish. I have a doctoral degree from MCBH University, USA, and specialize in healthcare academic leadership. Currently, I am the General Director of Maserati Training Center in Hasa, Saudi Arabia. I'm going to present a paper with title of Sleep Disturbance and Self-Care Strategies Among Women in the Reproductive Age in Hasa, Saudi Arabia. The author of this research, Dr. Aula Al-Musa, Dr. Aisha Al-Mafarfish, and Mrs. Noura Al-Umar. Today we gather here to shed light on an important issue that affects many mothers worldwide, which is sleep disturbances. As we delve into this topic, we aim to deepen our understanding of the challenges faced by mothers when it comes to getting quality sleep. We hope to explore some self-care strategies among women in reproductive age, specifically in Al-Hasa County in Saudi Arabia. Okay, let's take a brief introduction about the topics. Healthy sleep needs sufficient period, good condition, proper timing and consistency. Lack of sleep cause disruptions or disorder. As we know, sleep is a biorhythm process that is fatal for a life and best possible condition. Sleep performs a key role in the function of the brain and systemic bodily processes, including metabolism, hunger regulation, and the immune system function, endocrine system, and circulatory system. However, the quantity of sleep necessary for healthiness is uncertain. Most sleep specialists, as well as the National Sleep Foundation in 2002, advise that adults obtain 8 sleeping hours per night. Nowadays, sleep is often disturbed because of the domestic and professional demands for both sexual categories. With the aging, sleep length and condition alter. Sleep deficiency or disturbances lead to several biological and behavioral alterations in the body. A study has demonstrated there are a considerable research assessing the relationship among sleep and health relatedness. For instance, studies had demonstrated that females sleep problems. In addition, females are higher danger for a diagnosis of insomnia comparing to men. Being a female is a predisposing factor for sleep disturbances.
female category has been steadily characterized by sleep problems involving too much day sleepiness, problem in initiating or keeping sleep, and night awakening. Also, different hormonal and physical changes at adolescence, gestation, and menopause through a woman's life cycle can affect her sleep and lead to 6 specific medical conditions: shortage of sufficient sleep or the occurrence of sleep disturbances can significantly influence on a woman's daily life, including her social roles in the work and the family. Let's say the aim of the study. It was to assess the prevalence of sleep disorder among women in Hasa and to explore the self-care strategies among women in a reproductive age in Hasa. The ethical approval was taken from the research committee at King Faisal University in 2018. Let's see the methodology. A mixed methods design-wise was utilized. It gives researchers the chance to give a more broad overview and deeper understanding for the phenomenon. There is 2 phases. Phase 1, for the quantitative section of the study, the researchers use a self-administered questionnaire which was distributed to 500 mothers. The purposive sampling was applied to collect the data. The response rate was 62.4%, which represent 312 mothers attending health awareness exhibition in Hasa, Saudi Arabia. The questionnaire consisted of the following variables: social demographic characteristic, age, educational level, occupation, and number of children, and items, and statement reflecting knowledge and reasons for sleep disturbance. The quantitative data were coded and checked for accuracy, then entered into SPSS statistical software version 20. Analysis was performed by using the same statistical software package. Data were presented using descriptive statistic in the form of frequencies and percentage of quantitative variables and means and standard deviation. Phase 2, for the quantitative section of study, the researchers used in-depth interviews with 20 women aged 18 years and older, purposefully sampled from the participant for aging for further understanding of their self-care strategies. Questions for the qualitative section of the study were wide, permitting participants to answer freely regarding their self-care strategies. For the qualitative part, thematic analysis was done. Thematic analysis is a method which uses themes to arrange the meaning of the responses of the participant. The researchers interviewed the participant and explained the objectives of the study to them, and clarified any possible ambiguity to ensure completeness of and adequate feedback of the questionnaires. Verbal consent of the participant was requested. Inclusion criteria. Inclusion criteria include all women in the reproductive age from 18 to 49 years old, pregnant women, nulliparous, and multiparous with and without previous CS. Data collection and analysis, as I mentioned previously, we use SPSS statistic version 20, frequency and percentage. Collected data was kept confidential and was not used except for the study purpose. For the use of assessment tool, written permissions are taken via email from Sherlock C, who permitted to us the sleep questionnaire and sent us a copyright license to share or remix copies of the tool. The assessment tool was translated according to standard guidelines and modified. In summary, the original meaning of the questionnaires remained unaltered. Sleep disturbances are considered when the mean score is greater than 2. Result and analysis. Let's see the quantitative findings. Table 1 presents data for the 312 women. The table shows that more than half of the respondents, 54.2%, were in age between 18 and 25. The mean age of the respondent was 31.9. Out of the total respondent, 52.2 were nulli gravida and 47.9% were multi-parity. 52.2 were nulli gravida and 47.9 were multi-parity. In relation to the number of children, 52.9% had no children. Regarding the pregnancy, 97.1% were not pregnant during the study time. As regards to mental or psychological problems of the represented, 60.6% and had mental problems. Table 2, frequency and percent distribution and mean score for the sleep disturbance. It presents data for sleep disturbance of the 312 participants who completed the interviews. The mean score for having sleep disturbance between the study participant was 37.7, from the result 11.5% reported that they had experienced difficulty in falling asleep in most days, and 7.1% reported that they always had difficulty in falling asleep. In relation to trouble in staying asleep, 9.3% reported that they had trouble in staying asleep in most days, while 1.3% reported that they always had trouble in staying asleep. Regarding taking medication to help sleep, 84.3% never took medication, while 1.3% used some help to get to sleep in most days. Table 3, prevalences of sleep disturbances. Illustrate that the prevalence of sleep distribute between the participant was 91%. Figure 1, self-care strategies. Participants who reported sleep disturbance involved in many strategies to help and solve the problems. From these strategies, ignoring the symptoms or trying to continue sleeping or resting in bed, 57%, watching TV or internet, 50%, eating food or drinking hot beverage, 30%, praying and reading Quran, 18%, taking shower, 16%, making exercise to be more tired, 66%, using over-the-counter drug was 4%. Result and analysis, qualitative finding. We interviewed 20 women. Majority of participants reported consequences of their sleep disturbances. For example, problems in focusing, repeatedly dropping asleep throughout the day, loss of curiosity in entertainments and events, and believing that somewhat incorrect in their bodies. participant explained a powerful link among interrupted sleep scheduling, shortage of regularity, and sleep difficulties. As a well-formed connection between sleep disturbance, health problems, and daily performance was also affected. Participants described trying a variety of techniques to help enhance their sleep. This participant contained the use of selected substance as well as over-the-counter medication, along with non-pharmacological approaches such as mediation, reading, watching TV, exercising, and reading Quran and praying. In the qualitative finding, we have two themes. Theme one, describing the cause of the problem. Sub-themes one, childbearing and child-rearing factors. And as we discussed, most important themes that emerge through our data analysis, while acknowledging considerable overlap and interplay among them. We grouped these themes into the following categories. As I said, theme one, describing the problem with two sub-themes, childbearing and child-rearing factor, physiological factor. Theme two, self-care strategies. Let's see the sub-theme one, childbearing and child-rearing factor. A full night's sleep was seen as something to look forward to, despite being a rare experience. One of the participants said, "Poor sleep is one of my problems. I can't be fair between my responsibilities as a mother and my rights. So I feel uncomforting to go to bed. I always have something missing. I can't stop thinking on it." Another participant had a lot of tasks at home, work, and feel bad for this. The participant described, "I have a lot of tasks for my children, husband, work, home, and I cannot finish all of my duties when I can't sleep." Sub-theme 2, psychological factor. The experience of the delayed sleep phase, characteristic of the changes in the sleep style, was clearly described by participants. For example, one of them described she feels bad and cannot sleep alone. She needs to feel secure. One participant summarized her problem with sleep as she said, "She have nothing to do all day, no need to sleep." Another one said, "It's my nature. I cannot sleep more than 4 hours per day, and in some days, not continuously." One of them said, "She has a lot of problems. She cannot give up thinking on it. Thinking her problem is her problems." Another participant with bad dreams said, she suffered from bad dreams. She had to fall asleep. Another one suffered from loneliness. Feel on loneliness is her problem, which take her all thoughts. So she cannot sleep. Theme 2, self-care strategies. Participants describe sleep disturbance as extending beyond nighttime difficulties and having substantial effects on their social and family role, which they need to cope with. Theme 2, I just put some picture to make it clearer for you to understand. The style of current self-care strategies range from altering diet or exercise, watching TV, lying in bed, getting up to engage in some activities, listening to Holy Quran, or drinking herbal drink or warm milk. These are the strategies the participants use. Change the sleep location, medication, taking a hot bath, and taking OTC medication, and physical exercise. For one participant, The strategy to this problem described as take warm shower immediately before sleeping or trying to make some physical exercise before sleeping time to help her body and brain to relax. Discussion. Sorry. Another one seeks help from sleep disturbances by drinking warm milk or warm drinking like chamomile. It helps her to sleep. Also, she prefers to close all lights and be away from any noise. For one participant experiencing insomnia, distinct sleep habits developed, such as sleeping in her children's room. One of the participants feel loneliness and said, the best thing she did was to stop thinking, but she said it's difficult to stop thinking when she is alone. Creative methods used to solve sleep disturbance problem by participant. One of them described before sleeping, she tried to empty her mind. So she watched an internet program in her mobile while she lying on bed. Another participant said, the best practice to fall asleep is reading a book. Also, another participant said, she took a medication prescribed by her physician, and sometimes medication not prescribed by her physician just to fall asleep. One of the participants believed that help from God will solve her problem and described this as she believed that praying and praising Allah is her solution to fall asleep. In the same line, another participant said, reading Quran and praying give her relaxation until she sleeps. Let's move to discussion part. This study sought to capture in-depth descriptions of the self-care strategies among women in Al-Hasa, Saudi Arabia, and the preferences of sleep disturbances between them. The participants in this study reported that they had experienced difficulty in falling asleep in most days. This finding is similar to Berson's NJ 2006 study. He found that the majority of participants reported on one or more days that they had experienced difficulty sleeping during the previous 24 hours. In the present study, the primary reasons to the sleep disturbances was not to seek help or medical advice or ignoring the symptoms. They took it as a personal problem, and they tried to seek self-strategy to solve the problem. This finding is different from Stinson et al. 2006. They found that the participant considered the sleeping disorders common in their families and reasoning it as it is not uncommon among them. Regarding taking medication or asking help to sleep in this study, the majority never took medication. This results are in the same line with Godwin GS 1999 study, who found that the most commonly reported self-care strategies used by older adults were to ignoring their sleep difficulty or see how it's progressed. Stay in bed or rest and pray. These results were not in the same line with Henry D. 2013, who found that when help was sought from a medical practitioner, 1/3 of the sample sought help directly from a sleep specialist, and 2/3 first went to a practitioner with whom they already had a relationship. There are a huge number of the researchers examining the link between sleep and health-related outcomes. For example, Chris et al. 2003 found that insufficient sleep has been linked to increased psychological stress and lower self-related health. Obtaining optimal levels of sleep is associated with better health-related quality of life, confirmed by Lobrnes, BD, and Junior C. 2018. For qualitative finding, in this study, the self-care strategies for sleep disturbance that the participant reported use of variety of methods, including non-pharmacological methods such as sleep deprivation, medication, reading, watching TV, exercising and hard work, and reading Quran and pray, and over-the-counter medication. The results were in association with Henry D. 2003 research that has reported the styles of the self-treatment of symptoms range from taking OTC medication or dietary supplements, altering diet or exercise better, watching TV, doing yoga, lying in bed, getting up, to engaging in some activities, listening to subliminal tapes or engaging themselves in hypnosis, trying acupuncture, drinking alcohol in some non-Muslim countries, drinking herbal tea or warm milk, purchasing bitter matters, trying massages, changing the sleep location, mediating, taking hot bath, and napping. This all can help them to sleep. These results were not in association with another study who found that the participants reported they had not used herbal remedy or supplement, unlike other studies finding. This confirmed by Morney, CM 2006. Limitation of the studies was the small sample size, convenient selection of the participant. Let's go to conclusion. Sleep problems are more common in women through the life cycle, and in some cases are associated with or triggered by reproductive related events. Quite often, concurrent treatment strategies are done to remedy the problem. Self-care strategies involve a variety of responses. These strategies may be based on reducing or increasing activities, or using herbal or medication, or even over-the-counter drug. Thank you all for being here today. I hope that my presentation has provided valuable insights and information. Any questions?
Thank you very much, Dr. Aisha.
Thank you for your time and attention.
Thank you so much. Do you have any question for Dr. Aisha?
Matter including critical patients and the task. When used appropriately, delegation is safe and effective and does not compromise the patient experience. It is lessened the likelihood of staff burnout and can reduce preventable harm incidents that can occur when a registered nurse overwhelmed. So we have a guidelines for delegations. To be safe practice, right task under the right circumstance to the right person with the right direction and communication under the right supervisions, also evaluations. As the outline in joint statements by registered may only delegate elements of care and not enter the nursing process. Nurse should use the best judging when considering the patient's need when tasked to delegate and to whom. They must determine the level of supervisions required and should observe and verify that the individual to whom they delegate, as appropriate, it will be knowledgeable, skilled to perform the task. Delegation in nursing is important because it maintains accountability while assigning the task staff member. Often, the person delegated to accomplish a task may have other duties, and the delegation task can be outside their normal responsibility. When the delegation In nursing, there are some procedures it kept in the mind. Their nurses have many responsibilities, sometimes so many that it's a compromise them their ability to care of the patients adequately. The ability to the hand off or delegate tasks to available colleagues separate to their work among the health care team, ultimately leading to the more effectiveness in the unit and the work collaborative. As the result, productively often soars, as do the satisfaction score of patients and employees. Delegation can help nurses effective and managing their many responsibilities. It's a method for making their caseload more manageable, while still ensuring the patients receiving the care their needs. When used effectively, delegation can help save nurse time and provide other benefits such as building skill in delegation, allowing nurse to focus on more challenging tasks, create strong work relationship and motivating teamwork, promote to the most effective utilizing of a staff, improving residents and family satisfaction, discovering potential in other employees. Here are the tips. The first, be willing to yield some control, match ability with task, identify potential problem, be thankful and respectful. Set responsible goal, delegate responsibility fairly, consider delegation throughout your shift. Develop critical thinking skill, participate being patient, give advice and affirmation, learn throughout experience. So, be willing to yield some control. In order to delegate some of your tasks, be willing to let go of some of your control. You can still be active in monitoring to the progress of the task, but it may take less of hands of your approach as individual perform the task for you. Match ability with the task. Get to know your team members so you know that their strengths and weakness are. This can help when choosing who is delegated to the task, so to you assign it is the right person. Evaluate the factors such as education, skill set, and lessons status when determined. Identify potential problem. Before delegating, consider potential problem that may occur when transferring the responsibility so that someone, such as the lack of confidentiality in doing their task, try to come up with the ways to overcome these challenges to prepare for when they occur. Set up their responsibility goal clearly. Communicate the goal of the task to the individual you are delegating your assignment. This helps them understanding what they are working toward and what you expect from them. Consider making timeline of them. The deadline to help your delegate to stay on the schedule. Delegating responsibility fairly. When choosing who to delegate your assignment to, be fair your decision. Try to delegate the various employee rather than the same individual every time. Also consider the task you are delegated and try not to repeat an undesirable tasks such as bathing. Consider delegating throughout your shift. As soon as you notice you are unable to accomplish particular task, find someone to delegate the assignment to. If possible, try to delegate throughout your shift to spread the number of delegation out. Be thankful and respectful. Be sure thankful those who is complete your delegation task. Showing respect for them and helping you can help your development positively relationship and lead to great success in your delegation in the future. Develop critical thinking skill. Because delegation and critical thinking work together, it's helpful to improve your critical thinking skill. Being able to think
throughout a complex situation can help you make better decisions when delegation and find solution when a problem arises. Practice being patient. Since the delegation often involves employee performance and unfamiliar tasks, it may take some time for them to understand how to do it correctly. Be patient through the process as the individual develops their skill and knowledge. Give advice and affirmation. Since the delegation may perform a task outside of their normal responsibility, it's helpful to provide them with advice and how to succeed. Provide them with any necessary resource or training to help them succeed at the job duty, or let the delegated know they are alert you if a problem occurs while performing is the task. Learn through your experience. To become better a delegator, use the experimental learning. As you gain more experience in delegation, you may become more comfortable, assign other responsibility, and learn what works best. Evaluate how the delegation did. After the delegation completed the task, review how they did and how the patients respond to their help. When evaluating, consider any opportunity for improvement in the future. Factor to make delegation more effective. Guide factor make delegation more effective are: determines the goal, clarify responsibility and authority, motivate subordinately, provide training, establish adequate control, require complete work, two-way communication, adhere to the principle in the delegation. To determine the goal assigned should be clearly defined in the team of the goal or result. Expect if the person is accept the delegation, he should to be provided with details information with emphasize that his work is both necessary and important. So it is only after the clarification of all of these objects the person receiving authority would be justice to this job assigned them. Clarify the responsibility and authority. If a manager is performed effectively, he needs to know what is his job and with how much authority he has to perform it. With further, a supervisor who is not sure of the authority while evade issue or taking every question to his chief or for decision. This is essential of the whole problem. It is both in written of authority, responsibility relationship of each manager, and also its limitation on the authority of each position. Motivating subordinarity. This is motivating force. This is a moving force of the delegation. To get the best result, it is the duty of every manager to see the subordinate are motivated on their job willing and with an enthusiasm, unless they are giving definite assurance or the motivating by better weeks, improving worker, considering early promotion. Provide trainings. Delegation is rather the difficulties of process and can be achieved only by getting necessary training. Manager should give proper training to his subordinate to accept delegation. Establish adequate control. Control system in effective delegation should be such use and it can be free and the executive from the routine inspect, yet enables him to maintain his accountability. And this subordinate should be encouraged to following the means of the self-control. They should be given in the idea of the predetermined standard expected of them. Required to complete work. Under this doctrine, the subordinate expects from his boss to make a clearly understood of delegation so that for every step in this process of work, they need not consult their boss and thereby delay to the whole matter. At the same time, the manager plan for the guidance, a coach, and communication. Two-way communication. There is two-way communication between the subordinate and the superior. The superior must give the instruction in clear and unambiguous words, and he must allow the subordinate to seek clarification and guidance whenever the latter feels some difficulties. Adherence to the principle of delegations. Strict adherence to the principle of delegations, like party and authority and responsibility, unity of the commands, absolutely of accountability is essential for achieving success in delegation. What are the common problems of delegation? Lack of the clarity, inappropriate of an unacquired the team, mismatching the task and the skill set, absence of continuous communication, micromanaging and expecting the perfecting, pushing too many tasks, not allowing details from their convents. Principle of delegation. The nursing professional determines the scope and the standard of nursing practice. The registered nurse takes responsibility and accountability for provision of the nursing practice. The registered nurse directs care and determines the appropriate utilizing resource when provide care. The registered nurse may delegate the tasks or elements of care, but does not delegate the nurse process itself. The registered nurse considers facility, agency, and policy procedure that knowledge, skills, training, and awareness, experience of any individual whom the registered nurse delegated to elements of the care. The decision of delegation is based upon the registered nurse judgment concerning that care complexity of the patient, the availability and competency of the individual accepting the delegation, and the types of intensity supervision required. The registered nurse acknowledged the decision delegation involved in the relationship concept and mutual respect. The nurse leader are accountable for established system to access, monitor, verified, and communicating an ongoing competency required of the area related to delegation. The organization is accountable to provide sufficient resource to enable appropriate delegation. The organization agency is accountable for ensure that the registered nurse has access document, competency, information for the staff to whom registered is delegated the task. The organizational agency policy on the delegation are developed with the active practice participants on the registered nurse. This is a picture for decision tree for delegation and who will be delegated and who is not. If yes, how to be accessed for the organization. And each organization should have their own scope. For the legal and ethical consideration, when nurses make professional judgment, their decisions are based on the reflection of the concept and the universal moral principle as respect for the individual unique responsible person is the most. When a nurse makes fundamental of this principle, other principal derivation from this core principle are doing good, avoiding harm, telling the truth, keeping promise, and treating persons freely, respecting privileged data, and self-determining. A code of ethics status the primary goal and value of the profession. It's indicated a profession as concept, acceptance of the truth and responsibility with which it has been empowered by society. A code of ethics serves inform both nurse and society of the professional expecting their requirement ethical matters. and ethics could provide a framework within which nurses can make ethical decisions and fulfill their responsibility and public to other members of the health team and to the professions. So, in the conclusion, if the most case nurse receive appropriate work assignment and all are able to delegate, select, act, and unlicensed assistive personnel. When there is not the case, they are usually able to resolve problem through consultant and training or assertive assignment, which optimize the use available resource and assure safe, effective care. So this is the reference, and thank you for your hearing. I finished already.
Thank you, Dr. Alia, for your valuable presentation. That was
topic about the pregnancy health promoting the role of the obstetrical nurse. The learning objective at the end of this lecture, the student or the audience will be able to explain the national health goals, definition that relevant term, health promotion during pregnancy, obstetrical nurse and role of obstetrical nurse, discuss the different obstetrical nurse responsibility, antenatal, intrapartum, postnatal period responsibility, and also discuss about the achieving a high quality care for the women and newborn. The National Health Goal, the World Health Organization is developing new recommendation focusing on the management of the non-communicable disease for the pregnant, intrapartum, and postnatal women, thus to supporting the development of the new guideline and recommendation. The non-communicable disease such as the heart disease, cancer, diabetes, chronic respiratory disease. 90% of pregnant women to attend 4 or more antenatal care toward increase to 8 visits by 2030 to reduce the prenatal mortality and improve the woman experience of care. The first visit, it will be up to 12 weeks. The second visit, it will be in 20 weeks. The third visit, it will be in 26 weeks. The fourth visit, it will be in the 30 weeks. And the fifth visit, it will be in the 34 weeks. And the sixth visit, it will be at 36 weeks. The following that at 38, and the last one, it will be at the 40 weeks. The 90% of births to be attended by the skilled health person who are educated, training, and regulated to the national and international standard. 80% of the women who have just giving birth to access postnatal care within 2 days of delivery. 60% of the population to have access to the emergency obstetrical care within 2 hours of traveling. And 65% of the women to be able to make informed and empowered decision regarding the sexual relation, contraceptive use, and their reproductive health. The post-delivery visit, it will be after the 6th week of delivery, and the patient have the right to choose the good contraceptive method for her, and also give the good education and information for the patient about the sexual relation and reproductive health. Can you change the slide, please? What is the meaning of the health promotion during pregnancy? The health promotion during pregnancy, a healthy woman at the time of the conception has a better chance of having a successful pregnancy and a healthy child. Healthy care providing make it certain that pregnancy women receiving adequate knowledge and understanding of pregnancy, increasing their awareness of good antenatal visit and follow-up. A lot of the hospital now, she have the education program for the pregnant women who will educate her about changing of the pregnancy, the pain relief she can use in the during labor, and how she can make breastfeeding. And this one also building the friendly environment between the midwife and also between the patient. The obstetrical nurse are the high-trained nurse after their license and initial training. The obstetrical nurse are gaining clinical experience for several years in the obstetrical, the health of women, taking care of pregnant women and also their babies during their birth and laboring up to 8 days after the birth of the baby. The role of obstetrical nurse. The main role of the obstetrical nurse and the obstetrical nurse in the healthcare sector, including the service to the woman during maternity, it's including gynecological examination, prescription, delivery, and the laboring care, contraceptive consulting, and the many more. Now, we have obstetrical nurse clinic in the midwife also clinic in a lot of the hospital. The first visit for the patient, it will be with the obstetrical nurse. She will explain to her about the pregnancy and what is the physiological change during pregnancy, and she will make a lot of things for her. If she is high risk, she will make directly order to her to go to the doctor, or she can continue with the midwife. Definition of the antenatal period. The perinatal development, also called antenatal development, the period from the formation of the embryo through the development of the fetus to birth. The antenatal period responsibility, giving antenatal care to the pregnant women each trimester. In each trimester, she have a different care for the pregnant women. Assist antenatal mother by a history collection, physical examination, lab report, identify fetal well-being, and explain the EDD for the patient. And also in this visit, the obstetrical nurse assist the vital signs in each visit, and also assist the fundal height for the patient, check the level of the sugar, and also in each trimester. Assess a pregnant woman about general information regarding pregnancy and monitoring status of the fetus. When she is the first visit after the 12th month, at the 12 weeks, she can hear also the fetal heart rate of the baby. The help the mother taking the best possible decision for the care of themselves or this child. Support a woman access to reliability and unbiased information about the caring option. Respect a woman's choice of the birth setting. A lot of the hospital now, the patient, she have the responsibility, or the obstetrical nurse, she will help the patient to make the birth plan for the patient during her pregnant until when she is delivered, and also to educate her about the important essentially of the personal hygiene, rest, clothes, traveling, physical activity, sexual intercourse, dental care, nutrition, exercise during antenatal period. If she is not high risk and she can make the exercise, she will start the exercise. Giving the knowledge about the warning patient she is have a bleeding or she is decreased the fetal movement, if she is also a rupture of membrane of if, or if she has the true laboring pain, this she can go to the hospital anytime. Assess the high risk factor complication delivery and giving proper care for the case of the risk pregnancy. Definition of intrapartum period. Intrapartum period, it's caregiving to the mother and baby at the time of delivery. It beginning a laboring beginning and ending from the third stage of labor. The third stage is after deliver the placenta. What the responsibility for the nurse? She will give a proper nursing measurement during each stage of labor, prepare the positioning of the mother. If the mother she is fine and she doesn't have any complication, she have right to choose which position for her to deliver, giving the medication according to the physical order and also according to the pain score of the patient, which level she can receive the medication. Assess the fetal well-being to reduce the 60 to 70% of the stillbirth, and also prepare the mother for the laboring, providing adequate psychological support for the mother. Some of the hospital it's allowed for the husband or one of the family of the patient to attend with her during delivery. This will help the patient to decrease the anxiety and also the psychological supporting for her. Provide environment which is the safe for labor. The intrapartum period, also providing proper newborn care. In the first 2 hours, will just clean the baby, and all the time we try to keep the baby with her mother skin to skin as much as can, and also to improve the successful of the breastfeeding in these 2 hours, and also teach the mother about the appropriate method for the breastfeeding. Obstetrical nurse can do the research studies in order to improving the nursing measurement during the intranatal period. Research helped in improving the method of the delivery and providing more effective nurse measurement. Definition of postpartum. Beginning the period after the birth with where the psychological change return to the pregnant, return to the non-pregnant status. The postpartum responsibility closely, the obstetrical nurse, she will be the closely monitoring for the baby and the mother in this several hours. She will do the vital signs for the mother, and also she will assess the mother uterus and the amount of the lochia, mild, moderate, severe, and she will assist for the breastfeeding. After the patient, she is fine and everything is fine with the patient and the baby, she will transfer her to the postpartum care unit. At this time, the nurses are much more responsibility for the several factors such as administration, the pain medication. The next, please. The pain medication, giving the ice pack, monitoring blood bleeding as swelling. The skills are emotionally stabilizing and It is essentially for the nursing to cope up with the traumatic experience and also handle the hardship in a regular basis. The obstetrical nurse is capable of thinking quickly and critically for finding better solution for the patient. If the, like for example, if the patient she have a bleeding after postpartum, we thinking quickly about which type of medication we can give her, and also which type of management we can give to the patient. The nurse is also capable of the communication there inside and outside with the several patient and also with the several other member of the medical team. One of the skill is compassion, and by their nurse are working in the delivery and laboring ward, there is much more difficult, and inside that ward, the nurse are taking special care to the mom and also the to the babies. I remember one situation, one of my colleagues, she have delivery. I want to help her. What I will do, only I stand next to the patient and I put my hand in her hand. I encourage her to deliver. Only small things, it gives a good support also for the patient. After that, I receive a high appreciated from my manager about this small things, only small things, but it will really affect it for the patient. The WHO providing the support, achieving a high quality care for the women and newborn. The WHO providing the support for delivering essentially package of the high quality maternal and newborn service through the technical guidance and supporting two countries programs. In the particular, it has developed guidelines on the antenatal and intrapartum care and policy brief on the nutrients cared for the newborn. Obstetrical nurse has performing a different varied role during the different phases of the child bearing. The role will be through her full experience. There will help her to provide a better care for the mother, and also it will help the obstetrical nurse. Also, she will give her more experience in the next delivery or in the future delivery. Achieving a high quality care for the women and the newborn, healthy care must be effective. For example, like we increase the number of the visiting from 4 to 8 visit during pregnant. Also the population center, timely we give the patient the correct and accurate care in the appropriate time. Equitability, they can give all the patients receive the correct care and accountability all the same, and integrate the patient. She can contact with the midwife or the obstetrical nurse by the telephone visit or by the SMS during the working hours. They can effectively when we are giving the high quality care for the patient. The summary, the role of in nursing in midwifery of obstetrical care is crucial in the providing comprehensive and compassionate healthy care to women during pregnancy, childbirth, and postpartum period. Nursing play a vital role in the supporting and assisting women through the entry children process, working closely with the obstetrical midwives and other healthy professionals to ensuring that well-being of the both the mother and the newborn. All the medical team in the labor and delivery unit, working as a teamwork to save the pregnant woman and her fetus. Thank you so much. Any question?
Thank you, Dr. Sama. That was an excellent presentation. Any query to Dr. Sama?
The food composition and the hemoglobin level among adolescent females at King Faisal University. The outline of my presentation: introduction, methodology, and result discussion. Introduction. Globally, anemia affects developing and developed countries with major health and economic consequences. Anemia due to iron deficiency is a serious worldwide public health issue, affecting work capacity, intellectual performance, and pregnant irreversibly. Adolescents and young adult bodies undergoing significant physiological and physical changes, resulting in greater nutritional needs. It is common for young adults and adolescents to suffer from anemia. During adolescence and young adulthood, anemia plays a substantial role in a number of outcomes, and the severity of anemia has a substantial influence on this outcome. Some of consequences of this are a reduction in physical fitness and work capacity, as well as a reduction in school performance. Among the young generation, anemia is widely prevalent nutritional problem. The dietary habits of university students will continue into later life and play an influential role in health. Eating competence is a set of attitude and behavior defined by the Sutter eating competence model. Educating students on healthy eating practice and dietary pattern is vital, as they are the future of the world. A condition known as iron deficiency anemia is caused either by inadequate iron intake from the diet or by chronic external blood loss. Anemia is diagnosed when iron stores are low and hemoglobin level are to standard deviation below what is the normal for the patient age and gender. Around 26% of school girls age 7 to 14 in Riyadh have iron deficiency anemia. According to Bilal 2022, the population of the northeastern region in Saudi Arabia has a mild prevalence of iron deficiency anemia. The risk of maternal anemia increase among pregnant women and their babies, including stillbirth, premature birth, and low birth weight. Iron deficiency anemia causes 20% of prenatal and 10% of maternal deaths in developing countries. The maternal mortality rate will be decreased by 30% for every 10 gram per deciliter increase in the maternal hemoglobin. There is rigorous literature on anemia in adolescents and youth compared to that in women and children. According to another study, the iron deficiency anemia is prevalent in 30 to 56% of Saudi Arabia. In Riyadh City, a cross-sectional study among female adolescents from 16 to 18 revealed prevalence of 40.5%. This is in Riyadh City. The aim of this study, the purpose of our study was to determine the prevalence of anemia among healthy female nursing students at King Faisal University in Hasa, Eastern region, Saudi Arabia, and its associated factor. Methodology. In this cross-sectional study, blood samples were analyzed to determine the prevalence of anemia among nursing students by measuring hemoglobin concentration and assessing their body mass index, dietary habits, and awareness of their food intake, and in order to determine the prevalence of anemia. Additionally, participants were asked to fill out a questionnaire regarding their nutritional knowledge and habits during January and April 2020. A survey was conducted with first-year students. Participants, a convenient sampling technique was used to collect samples from all first-level students during lab time. A total of 83 students between the age of 18 to 22 participants in the study. All of this in the first year. Ethical concentration. A protocol for this study was approved by the Research and Ethical Committee at the King Faisal University, number KFU-REC 2020-12-18. Confidentiality was maintained regarding the information of each participant. Each participant was informed about the experiment and provided written consent before blood was collected. The study objective and experimental protocol were explained to the participant, and the participants who were not interested in providing their blood voluntarily will excluded. Setting. The Department of Nursing in College of Applied Medical Science, King Faisal University in Hasa, Eastern region of Saudi Arabia. Instrument used. Based on the prior literature and the study of Messias 2040, we developed a structured questionnaire. Additionally, the researcher used the guideline for assessing nutritional related knowledge, attitude, and practice manual. There were three major parts in the questionnaire. First, information about the individual socio-demographic characteristic like age, marital status, history of obstetric, and gynecology status. Second part, we measure the hemoglobin level and the body mass index. Also, the weight and height using portable balance. Third part, nutritional and anemia knowledge, practice, and attitude questions. Procedure. A capillary blood sample is taken to test the hemoglobin level. The normal range is dependent on attitude and region. Female adult from 12 to 16 gram per deciliter. A student with hemoglobin level less than 12 gram per deciliter was considered anemic according to WHO criteria for anemia diagnosis. Hemoglobin should be greater than 12 gram per deciliter. Result: in the first table, we show the demographic data of the participant are shown in this table. Participant age range from 19 to 21 with mean of 19.8 plus or minus 0.7. In terms of marital status, 81.9% were single. And in another line, more than half of the participants, 15.6%, had a high family income. Also, 25.3% had heavy menstrual cycle. We show also 72.3% had a menstrual period lasting between 5 to 7 days. Next table shows the means and the standard deviation of the participant clinical data. The hemoglobin level was 11.06 plus or minus 1.43. The study participant ranged in the weight mean is 56.4 plus minus 10.4. Also, the height mean is 158.3 plus minus 4.7. Body mass index means is 22.3 plus minus 4.07. The knowledge of studies participants regarding anemia and iron-rich foods. There is no doubt that most participants, 97.6%, have some knowledge of anemia. Nearly 1/3 of the participants, 38%, have a fair knowledge of symptom of anemia. In particular, 54% have a fair knowledge of the effect of iron deficiency on children, while 50% have some knowledge of the effects of iron deficiency on women. A majority of participants, 91%, have a fair understanding of anemia causes. Knowledge of studies participants regarding anemia and iron-rich food. Nearly 2/3 of participants know that meat and organ are food rich in iron. Regarding knowing the food help the absorption of iron, 31.3% are aware that fresh citrus fruit are vitamin C rich food. On the same point, 50% of the participants know the coffee and tea decrease the iron absorption. Consumption of iron-rich food. On the last day, only 19% people consumed food containing unprocessed meat and meat or liver. Also, 53% of the participants didn't consume any iron-rich food the previous day. Nearly 1/4 of the participants consume citrus fruit or vegetable like lemon or organs, dark green leaf vegetable, bell pepper, and juice made from them. In more than half of participants, citrus is consumed after meals. Nearly 2/3 of participants drink coffee or tea. 27 participants drink coffee or tea during the day but not at the meal time. Attitude of the studies participant regarding anemia and the taste of iron-rich food. There were 81.9% participants who were not sure of the severity of this condition. Only 10% considered it serious. The taste of iron-rich fruits and vegetables is disliked by 60% participants. In this figure, we show the total knowledge score about iron-rich food. A majority of participants, 60%, had fair or moderate knowledge of iron-rich food and anemia, while 50% had high or good knowledge. Also, this figure shows the hemoglobin level of a study participant. Over half of the participant, like 59%, had low hemoglobin level, which is surprising. Association between hemoglobin level and knowledge score. Study participants' hemoglobin level were significantly correlated with their knowledge about iron-rich food and anemia. P-value equal 0.005. Association between hemoglobin level and the clinical data of the study's participant. Clinical data such as chronic disease, heavy ministerial cycle, and the supplementation drug were significantly correlated with hemoglobin level. The discussion. Most part of the world have extensively studied anemia in women and children, but Saudi Arabia Eastern region particularly lack information about its prevalence among university female students. 81 of participants in this present study have some information about anemia. A recent study found that 91% of the female adolescents had heard about the anemia, which is similar to the percentage in this study. Jalambo at ETAL 2013. The percentage was higher than that found in Palestine, where 71.8% had heard in anemia. It was found in the present study that 59% of the participants had anemia and low hemoglobin level. It is consistent with the finding of Al-Hassan 2015, which found that 64% of Chiba University female students were anemic. An additional study in Bangladesh found that 55% of the students were anemic. The mean of hemoglobin level in the present study was 12.06, a little bit low than normal, but higher than the average hemoglobin reported by Tiba University, which was 9.8 gram per deciliter. Sultan NN found that anemia preference was 26% in Emirate college student whose mean hemoglobin was 12.3 gram per deciliter compared to 59% in the present study. A high percentage of students use the iron supplementation drug in the present studies. Similarly, a study done in the Saudi Arabia found in 37% were using supplementary drug in the study of Musa 2020. Conclusion. In summary, anemia among the Saudi female university students is categorized as mild public health problems by WHO. It was found that anemia was highly prevalent among female university students. Further, the consumption of food that decrease iron absorption, such as tea and coffee, and irregular meal consumption may also be contributing factor to anemia in the study population. There is a need for further studies to clarify the causes of anemia in healthy girls using several indicators. Thank you. Any question?
Thank you very much, Dr. Amal. If there's any question for Dr. Amal, say it. Actually, it's very interesting research.
Precisely at Baturi Health District of Cameroon. As a plan of the work, we have the introduction and the research problem. We have the research question, the objectives, the materials and methods, the results and discussion, and then we'll conclude and make some recommendations. Looking at the research problem, adolescent pregnancy and abortion, in spite of its serious public health and social concerns, seems highly neglected worldwide, and more specifically in developing countries with restrictive abortion law, including Cameroon. Worldwide, we have a high population of adolescents who do not sexually manage their sexuality correctly, and this leads them to fatal consequences sometimes for a lifetime. Adolescent pregnancy and abortion is plagued with high prevalence, morbidity, and mortality, where we have close to 2.1 million girls aged 15 to 49 years and 2.5 million under 16, with 1 million under 15 years giving birth every year, with the majority occurring in low and middle income countries, that is WHO. We have 5.6 million adolescents every year committing abortion, among which 3.9 million are unsafe, accompanied by serious consequences, ranking adolescent maternal morbidity and mortality the second cause of death in girls aged 15 to 19 years. The rate is even higher in girls who are less than 15 years. Looking at Africa and Cameroon in particular, we have exceptionally high rates of abortion and pregnancy among adolescents with serious complications, yet true estimates are difficult because of lack of quality research in our setting. This is even more worsened with the issue of restrictive abortion law, sometimes even in contrary to normal health policies. Cultural norms sometimes conflict with medical laws, as in some areas in Cameroon, we have early marriages, which is encouraged, and sometimes even abortion, even though illegal, even with proven illegality in abortion, the prosecutors are never prosecuted legally. With the first globalization more to that, and with increased career pursued by parents, including mothers, coupled with high moral decadence and violence, especially against teachers, most adolescents are left to themselves and abandoned both by their families, the parents in particular, and the teachers, who most of the time the parents depend on them for their sexual and reproductive health education. Cameroon in particular experiences 1 in 4 adolescents, 15 to 19 years, becoming mothers, becoming mothers, and battery is not left out. Unfortunately, Cameroon does not have any national record of adolescent pregnancy and abortion. This is why most research are just statistics gathered from isolated researchers. Unsafe abortion, in spite the illegality, is very rampant in Cameroon and not reported. Even cases that are reported are not usually prosecuted. Looking at Cameroon still, even the research that is being carried out in Cameroon, most often they are non-experimental, sometimes contradictory, and more institution-based. Mandates that are used in Cameroon most often are not contextual, most often imposed by foreign agencies like WHO, which does not match with the Cameroonian context, reason probably why the very high rates of adolescent abortion and pregnancy in Cameroon. The few programs that are even launched in Cameroon, most often they are very short term, they are not evaluated, and they are not focused on adolescents. Most often adolescents are mixed with youths and even children, making the issue very difficult to be able to assess the status of adolescents in the country. To add to the problem, we have much less implication of families, especially men, in spite of their capital role in curbing efforts regarding adolescent sexual and reproductive health. Adolescents, pregnancy, and abortion is not prioritized in Cameroon. We have poor funding, we have poor infrastructure, which even goes to complicate the issue much more. All of these, in a nutshell, is indicative of a failure in primary prevention efforts in curbing adolescent pregnancy and abortion. This led the researchers to ask the question, how are adolescents pregnancy and abortion kept by adolescents in Baturi Health District of Cameroon? As specific research questions, how do adolescents of Baturi view adolescent pregnancy and abortion? How is adolescent pregnancy kept by adolescents of Baturi? How is adolescent abortion kept by adolescents in Baturi? And what workable strategies by these adolescents is adaptable to curb adolescent pregnancy and abortion? It was in this slide where objectives were set as the general objective to determine the strategies used by adolescents to curb adolescent pregnancy and abortion. As specific, we want to explore the views of adolescents with respect to adolescent pregnancy and abortion. We want to determine the strategies they used to curb pregnancy, the strategies they used to curb abortion, and the workable strategies that they think can help curb adolescent pregnancy and abortion in Baturi. In view of realizing these objectives, a methodology was set up where we opted for a qualitative cross-sectional exploratory phenomenology study, since it's a new phenomenon to us. We sampled 23 adolescents for in-depth personal interview, 54 adolescents for 6 focus group discussions. The focus group discussions, we parted the adolescents by different age groups, the early adolescents, the middle adolescents, and the late adolescents. So it gave us 2 focus group discussions for the 3 classes. We purposefully sampled these adolescents because we're interested in the views of each of the different age classes, hoping they will normally live the experience, the phenomenon differently. Data was collected using semi-structured interview guide and focus group discussion guide. Looking at data analysis, a narrative thematic inductive constructivism was the epistemological position opted. We wanted to bring out the knowledge from the adolescents themselves regarding the phenomenon that they are living. So we construct our knowledge from their views, no planned event to that. As of results and discussion, we had the adolescents parted in different age class. We had the early adolescents, we had the middle adolescents, we had the late adolescents. They were all taken differently for in-depth personal interview and also taken differently for focus group discussion. Looking at the results, what came out from the data collected, we had five main strategies they use to curb adolescent pregnancy and abortion. We have sexuality and STI awareness. We have parent-child communication on sexual and reproductive health. We have parental control. We had use of contraception. We have specific strategies that they implemented to prevent abortion. And then we also try to look at the workable strategies that they think can help them better curb adolescent pregnancy and abortion. Looking at sexuality and STI awareness, all adolescents had some considerable knowledge on adolescent pregnancy and abortion, even though some were wrong, but they all could well define pregnancy and abortion, but wrongly classified adolescents. All adolescents saw adolescent pregnancy, most adolescents see adolescent pregnancy as no problem, provided the author of the pregnancy is financially viable to assume the responsibility for the pregnancy. They only saw it a problem when the finances are not actually there. But all of them view adolescent abortion as bad, mostly because of the health consequences on the pregnant adolescent girl. Most of the adolescents, the early adolescents, got their knowledge from the quarters, that's gossips around, and from their school, whereas the middle adolescents and the late adolescents, most of them got their knowledge on adolescent sexual and reproductive health from friends and the media mostly. Family came in as a last source of information or source of knowledge on their sexuality. This, however, could reflect the taboo that is rampant in most African family and Cameroon in particular when it comes to sexual and reproductive health communication. Many research have revealed that, such as a research in Cameroon by Mankaa and UNFPA, is the same phenomenon in India, but rather a contrary phenomenon in Royal Chile, where they instead saw that the family, that is the parents, were the primary source of information to adolescents regarding their sexuality. We look at the predisposing factors. Most adolescents blamed friends, social media, and poor parenting. Most often, parents don't care for their needs. Parents are hardly there. They are busy, and that is what pushed them to indulge in irresponsible sexuality. And this is similar to the research in Mexico by Samano. However, it is contrary to the research in Cameroon by many researchers. Some rather saw adolescent sexual and reproductive health not prioritized as the main reason for increased rate of adolescent pregnancy and abortion. We had Acue and WHO, who rather saw restrictive abortion laws and poor cultural norms being responsible. We had SOCPA and the CONIM, who saw poor sexual and reproductive health services rendered to these adolescents. We had WHO, who saw weak health system and governance in Cameroon. And we had Hadi, who rather came in to say that the real issue and really insisted in his research was because men who are actually involved in adolescent pregnancy and abortion are not served by family planning service. Rather, they are treated passively, whereas they need to be active participants in the service rendering when it comes to family planning. We see the consequences of adolescent pregnancy and abortion. The adolescents are well aware of the consequences, including forced marriage of these adolescents to the author of the pregnancy, school dropouts. We see issues of infertility coming in, death, abortion, family shame, child delinquency. These are some of the consequences that the adolescents listed as responsible for as consequences of adolescent pregnancy and abortion. And many research has also revealed these consequences, including those of a man in 2020 and WHO in 2019. We look at parent-child communication on sexual and reproductive health that was raised by the children. They said it is very good to communicate with their parents on their sexuality, but it is very, very rare and non-assertive. Usually, most often, the parents come in to talk to them when they have done something wrong concerning their sexuality. And that is how, and most often in such a situation, they don't learn anything because they are generally in the defensive. They desire to discuss with their parents on their sexuality and trust the education of their parents, but are generally afraid and expect their parents to initiate the conversation. Most parents start very late, according to the adolescents. Generally, when they have indulged, the adolescents have indulged in sexual activities and then committed a crime, that's when the parents come in to sanction them or to scold at them. And this could be explained by the fact of a transgenerational sexuality taboo and cultural norm, which is rampant still in the African family, confirmed also by a study in Nigeria by Kaiser and Family Foundation. However, it has also been revealed by a study in 2010 in Nigeria that most children whose sexual education starts late, say 16, they have a higher rate of adolescent pregnancy and abortion compared to those whose sexual education on sexuality started early. This is also in like with similar to the study of Doniga 2010, who carried out a study on attitude and belief formation regarding sexuality, who says these attitudes are formed well before age 12. Thus, sexual education should reach children before age 12. Concerning parental control, most children said they desire their parents to be interested in every activity of their life, not only their sexual life, but that the parents are usually hardly there and they are busy, only showing up when they have committed crimes with sanctions. This study is in line with that of Samano 2017, who revealed in the study that pregnant teens had a family background of teen pregnancy and that the girls disclosed feelings of repression, loneliness, and indifference from their parents, leading them to unprotected sex without fear of pregnancy. Concerning use of contraception, most adolescents refused responding on which contraceptive method they are using. Very few of the late adolescents talked of condom for the men and then calendar for the females. And all of them said abstinence is best, but it is impossible. And when we asked, they said it's just impossible in their community. That was the answer they gave. And the females attested that the men sometimes refuse to use the condom for reasons they cannot explain. Norplant as a contraceptive method was, however, mentioned as a method forced by some parents on some adolescents who are very recalcitrant and come with repeated pregnancies. Regarding still use of contraception, we had two studies that was carried out two systematic review studies in low and medium income countries who revealed rather a contrary finding, saying that poor use of poor access to family planning service and poor quality sexual and reproductive health service is more implicated in adolescents not using family planning methods. That is Hindin 2016 and Dano 2015 for a systematic review. Dano 2015 on its part still revealed that there is great paucity in evidence regarding out of facility-based strategies on adolescent sexual and reproductive health. Most attempts are usually in hospitals or in schools, and this leaves adolescents and their families with much gaps which they need to fill and which they don't have the competencies to fill that, neither the parents. Regarding the specific strategies to prevent adolescent abortion, all adolescents, they said the only method is through sensitization and a few talk of helping the adolescent girl to go for medical care, giving of physical and emotional support, and preventing stigmatization that the child does not feel rejected to go for an abortion. An adolescent puts it in this word: which strategies can you people use to prevent adolescent pregnancy? A late adolescent said, ha, ha, ha. There, it is impossible. It is normal here that children begin sexual activity early. It is even encouraged by parents. If not, how will you think that a girl of 12 or 14 comes to the house with a plastic and you just take it without asking any question? Just continue sensitization of parents and children on the dangers of adolescent pregnancy and abortion. Maybe someday it will help. That was the response I got from a late adolescent when we asked about methods to reduce adolescent pregnancy, to reduce adolescent abortion that they can give. This, however, is contrary to a study in North America, which revealed that school-based clinics had positive effects on pregnancy outcomes of teenagers and positively influenced decision to use contraceptives and their use and their desire not to repeat pregnancy. This could be explained by the fact that in North America, sexuality conversation is very free. It's a little more liberal than here. Even in schools, parents revindicate when they talk of teaching comprehensive sexuality education in Cameroon. So it's still a real issue to be addressed by all concerned parties. Looking at workable strategies concerning prevention of adolescent pregnancy, most adolescents said it's a lost battle because it's a habit that is normal and even sometimes encouraged by parents in the Baturi community. Notwithstanding, proposed strategies include sensitization of parents and children, teaching parents to communicate assertively with the adolescents, free sharing of condoms and encouragement of use of condoms by the adolescents, establishment of laws by local chiefs to sanction families whose adolescents get pregnant and whose adolescent impregnates another adolescent, and empowering adolescents financially. That is, getting them to learn a trade, believing that they being involved in a trade, it would reduce their tendencies for involving in sexual activities without goals, and would also reduce their vulnerability to undesired sex because they are forced to. This also is strengthened by the study by Nkoma, that was 2020, who did a systematic review and saw that empowering girls with lucrative activities help in a great way to get them to be able to carry out responsible sexuality and reduce pregnancy and abortion. As workable strategies to prevent adolescent abortion, most of the adolescents in Baturi centered their strategy on physical and emotional support and avoidance of stigmatization of the adolescent girl. Notwithstanding, a great point was really raised by most of the adolescents, which they recommend that all adolescents who get pregnant should be sent for consultation, not by a medical doctor, but by a pastor, that in consulting the pastor, most of them would be strengthened spiritually and morally to be able to keep the pregnancy to term. As a conclusion, we say many strategies have worked elsewhere. Africa, Cameroon, and Baturi are still lagging greatly. We want to recommend researchers to focus more of their research on health institution side, especially research on the family and the community, because up till date, we've seen that most research has been institution-based and we are still getting the very bad results. Why not get to the people who really live the phenomenon, that is the adolescents and their parents or their families. The policymakers, we are recommending they support high quality research, and they also help in the training of healthcare workers on adolescent sexual and reproductive health care, because it is really, really lacking. And thirdly, we are recommending the healthcare professionals to self-involve themselves to build their capacity on adolescent sexual and reproductive health, and to render adolescent sexual and reproductive health service more adolescent friendly. In a nutshell, the problem of adolescent pregnancy and abortion, it's a complex one that needs synergy. We are employing all the stakeholders that are concerned, the policymakers, the community stakeholders, the religious stakeholders, the healthcare workers, the families, the adolescents themselves, all who are concerned to work in collaboration so that in the near future, we can move from seeing our adolescents in the sad stage, in sadness, adolescents becoming mothers, adolescents being forced in marriage, to see them become happy and be able to fulfill their potential. This brings us to the end of our presentation. Thanks for your keen attention.
Thank you very much, Ms. Atanga, for this very exciting topic, actually. Who want to ask Ms. Atanga? There's any question for her? So we can move to the... we'll talk about to raise awareness about the unique health challenges faced by patients with disabled. The second objective to empower the patient with the disabilities and highlight their needs. Third one, to advocate for the certain of the patient with disabilities friendly environment that support the health and well-being of them. Fourth one, to inspire the audience to take action and promote policy and program that prioritize the health of patients with disabilities. The last one, it will be to provide the opportunities for the audience to engage in the question and answer sessions to address their specific concern and the question related to that topic. Table of content, we'll talk about 10 important points. The first one, disabled and access to the healthcare in low-income context. Disabled people can be healthy. Third one, healthcare needs of persons with disabilities. Fourth one, healthcare meeting the need of person with disabilities. Fifth point, it will be access to the healthcare, universal health coverage and disabilities. 6.1, access to the specialist service among people with disabilities. 7.1, barriers in accessing healthcare. 8, improve policy response. 9, improve health promotion. The last one, monitoring and inclusion of people with disability in healthcare. Let's take a brief introduction of disability. The people with disabilities are highly stigmatized with our society and across the global. The media often present disabled people through just two-dimension narrative, tragedy and overcoming. The United Nations Convention on the right of person with disabilities is a human rights instrument on the international level intended to protect person with disabilities dignity and rights. A person with disabilities actually have the same health need as every other member of the population, include immunization, screening, sexual and reproductive health, and all other aspects of regular health. They may also have additional or more complex health needs. Because of environment and the consequence of environment, person with disabilities may face barriers in accessing health care. In fact, it is especially crucial for healthcare workers to better understand the experience of patients with disabilities, because it is too often the social, not medical, effect of disabilities that most directly impact quality of life and the overall health outcome for people with disabilities. Did you know that the healthcare providers are required to offer everyone access to the medical service without discrimination on the basis of disabilities? Do you think that? Okay, we know. First one, disability and access to the healthcare in low-income context. Let's talk brief about this point. The majority of individual with disabilities level in low-income context. Recently, there has been an accumulative of evidence that a barrier to healthcare access exists for the person with disabilities in less resources countries. Access to the healthcare, even in wealthy country, is often difficult for the person with disabilities. But in poorer country, the challenge are exacerbated, combining physical, financial, and attitudinal component. There are many barriers actually to the healthcare experienced by persons with disabilities.
What is Numer doing outside? This long leg. You cannot stay with this long leg inside this
Excuse me? Can you can you make it mute? Thank you. There are many barriers to healthcare experienced by persons with disability in resources-poor settings in Africa. Okay, like everyone else, persons with disabilities have healthy needs by virtue of their healthy condition or environment. They often, but not always, have additionally health needs. These should not define them, because to have a healthy need is a part of human condition. The issues of prevention is also controversial within the disability right community. Ensure that the person with disabilities can access to the health care promotion, prevention, screening, and rehabilitations, and other mainstream and specialist health services is a unique question. Okay, rural access,
It's 16:30.
Rural access to the health service, disability and access to the health care among the poor rural population has received little attention. There is scarce data on their health needs. Many studies suggest that persons with disabilities in rural area have more problems and issues regarding their health care than persons with no disabilities in rural area, especially when it comes to the healthcare access. Second point, we'll focus on the disabled patients and people can be healthy. As you know, objectively, according to the International Classification of Functioning, disabled and healthy, all people with disabilities have a healthy condition. However, having the environment does not mean being unhealthy. Moreover, objective health is not the same as subject health. Let's go deep to understand this concept. Okay. Many people have static impairment, for example, blindness or deafness or missing limb, but reported feeling healthy. Regardless of impairment or illness, people can be in good health. Because what? Because they eat a good diet, take exercise, get enough sleep, and in a good emotional state, and other healthy behavior. The third point we'll discuss healthcare need of person with disabilities. There is a good evidence that the person with disabilities are more likely to have a poorer health than the general population due to a variety of possible mechanisms, which may be different from people with different environments. First, some environments don't directly affect health. They could be considered more as difference in functioning, such as deafness or some aspect of the neuro diversity. For example, people with spinal cord injury are increased risk of pressure sore and urinary tract infection. People with Down syndrome are more likely to experience congenital heart disease, impaired hearing, and early onset dementia. People with blindness due to diabetes may also experience kidney disease. People with the cerebral plasia may develop osteoporosis. The third point, disabled people are also higher risk of comorbidities, where the cause is less direct. Often, a comorbidity may result from the increasing risk of poverty and social exclusion that the person with the disability may face. Disabling barrier and isolation can impact person with disability in very diverse way. For example, people with long-term physical condition are 2 to 3 times more likely to have mental health condition, such anxiety and depression. We talk about the fourth important point for the all healthcare provider should to be know. Healthcare meeting the needs of persons with disabilities. Persons with disabilities require the same general health services as persons without disabilities, from promotion, prevention, treatment, to rehabilitation and palliative care. People with disabilities may also require different type of specialist services, like what? Rehabilitation or assistive device, or adaptation to how services are offered. Sign language communication. To achieve health equity, access to the health is a vital prerequisite Access to the health is not just about physical access to the healthcare facilities, but also cover factors such as what? Such as quality, geographical accessibility, availability, financial accessibility, and acceptability of services. Fourth point, access to the healthcare, universal health coverage, and disabled. Access to the healthcare is a development issue, a key focus of a sustainability development goal 3, good health and well-being, is to improve access to the healthcare service for all through the achievement of universal health coverage. Universal health coverage means that all people and communities can use the promotive, preventive, and curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring that the use of these services, all these services, does not expose the use to financial hardship. The 3 dimensions to consider when moving toward universal coverage. The first one, population coverage. The population coverage exists of universal health coverage, focus on the access to the health for all, aiming for health care that is available to the entire population. People with disabilities may experience poorer access to the health care services and consequently high unmet needs. The second one, financial coverage. The second component of universal health coverage, that the health care need to be affordable even for the poorest in the community. Financial barriers to accessing the healthcare are widespread for many people, but may be exacerbated among persons with disabilities as they are often marginalized, less likely to be employed, and on average are poorer than those without disability. The third one, service coverage. The service exists of the universal health coverage model focus on the type of service available. The full range of healthcare services that people with disabilities may need, both general and specialized, should be available in order to achieve true universal health coverage. It's clear until now. Let's move to the 6th point. Access to the specialist services among people with disabilities. Actually, people with disabilities may benefit from the specialist services as a result of their environment, which include physical therapy, assistive device, speech and language therapy, psychiatric, and more. Many of these services are usually now as rehabilitation. It should be noted that this is a complex concept to define. The same term and is also used of vocational rehabilitation. Rehabilitation of offended, drug like alcohol rehabilitation. 7 point, we'll talk about the barrier and the accessing the healthcare, the barrier facing the disabled and accessing to the healthcare. Persons actually the disabilities are facing with the range of barrier when they seeking healthcare. Strategies are required to overcome these different barriers in order to achieve universal health coverage and the fulfillment of the right. People with disabilities are diverse group, and people with different environment type may be particularly vulnerable to certain type of barrier to accessing services. Barrier will also vary in a different geographical and cultural setting and in different policy environments. A barrier that is perhaps conceptually straightforward, arising from limited physical access to the healthcare facilities. Obstacles can make it difficult to gain entry into the facility, but also to move through elevator or doorway into treatment room or use the bathroom, having accessible, adaptable furniture or equipment is also important consideration. Other barriers can face the disabled may be less well recognized and understood. For example, we can take the people who are deaf or have other communication difficulties. Cognitive or psychosocial environment may miss out on information or on being informed about their option if there is a lack of sign language or other adapted communication tool. Easy read information, picture, symbol. People with the visual environment may not be able to read letters from the health professional or instruction regarding medication. So all healthcare providers should be put in their mind what is the barrier and difficulties all the disabled can be faced during the communication inside the work. 8, improving policy response. As we are healthcare providers should be improved and enhance the policy response. WHO globally disability action plan has a target to develop or reform health and disabilities laws, policies, strategies, and the plan for consistency with the principle of the Convention on the Right of Persons with Disabilities. It encouraged countries to review and revise existing policies and eliminate discrimination prevention to ensure better access for and including access for the including person with the disability in health and other sector. The 9th point, improve health promotion. Its most important point should be focused. All healthcare providers should be focused on it. As we know, the health promotion can focus on encouraging healthy behavior, such as what? Such as exercise and good diet and taking part in preventive programs like vaccination, screening. Healthy promotion activities must be inclusive of people with disabilities so that they are available in appropriate formats. However, these activities alone may fail to improve health for people with disabilities as they don't address some of the underlying drives causing their poor health: poverty, exclusion, and discrimination. Health promotion program should be more holistic and also address these issues, and her CPR program may provide good example. Improving affordable services for people with disabilities is a critical step in improving coverage. Let's move to the last point for the improving the healthy life for the disabled patient. Monitoring inclusion of the people with disabilities in health care. Monitoring the inclusion of persons with disabilities in the healthcare system may also several where are gap in provision. The WHO has gathering data and developing technical guidance and training resources for policy makers, health workers, and manager and program implementation to support health system and delivering health services that are more inclusive of people with disability. Here, the last slide. Thank you very much to all for listening. If you have any question, you can ask. You don't have any question about the disabilities? Thank you very much. Thank you for listening. So we move to the other speaker. Wait. So we move to the acupressure treatment and cervical lordosi loss to present Siriago Balanandiri from the Italy. I know it's a difficult name, but you can present yourself and talk about yourself. Thank you very much, Mr. Sirajo.
If it's possible, I'm not be able to share video until the previous relay. Oh, okay. Many thanks. That's fine. Okay. We want to explain, it's necessary and fundamental to have a look to the background. And the background begins with these questions. So, do you know that losing curve in the spine, it means just the same that reduce at 50% the charge capacity of the spine itself in accordance with Dalton's law? Every time we look at full spine X-ray radiography we perform, we are well aware about the Dalton's law. Just like in these cases. As you can see, these three cases in the coronal view are so different. But if you take a look of the sagittal view, you can see that they act just like the same. So we want to deeply investigate this finding, and also if this is not a very important finding from an orthopedics point of view, because the cervical trait is extremely rarely interested by scoliosis, it is instead a great relevance from posturology point of view. And we design a retrospective study analyzing 300 full spine X-ray examination in order to find if there could be a relationship between the physical and the subject parameters of major importance and the cervical lordosis loss, just as age, gender, Cobb angle, and type curve. it's true, we really have some doubt beginning this study, and the result confirm our doubts, because the p-value that we calculated on the data collected from the 300 cases examined says us that there is no type of association between age, gender, co-bangle, and curve types. So we thought a theory. And this theory means that maybe a reactive neurological response making contract the neck muscle may be the probably reason of the finding. Trying to relax muscle of the neck may be a way to go to find a proof of our thinking. And then, now we can explain our study proposal. So, we think to enrolled subjects that have a cervical lordosis lost, then undergone them to a treatment, maybe acupressure or facial treatment, and control them before and after the treatment with a standardized system of postural analysis. Some detail more. Subjects do not ask to be affected by AIDS. They only be less than 20 years, and they have a diagnosis of cervical lordosis lost, made by radiography or another system, just like a system for postural analysis. The system of postural analysis could be one of the most common comers or other, just like the one we have designed. Other useful tests or measurements may integrate the study analysis. Also, the treatment could be an application of acupressure technique, just like, for example, the Shiatsu by Masunaga teaching on TCM meridians. Or, another example, a fascial technique, just like the one was proposed by Luigi Stecco. Naturally and obviously, the protocol we speak about, such as the enrolling protocol or the measurements protocol, or also the treatment protocol, have to be defined in their details, depending on also the available and the disponibility of the resources in the single place. Now, we want to leave you a take-home message. That's the core of our idea and our aim, and the aim of this presentation. Cervical lordosis loss is surely one finding that is not negligible and is really important, especially in the two first decades of life, and it deserves a dedicated study to know, investigate if it's possible, and is possible causes, and there is possible solution to ensure better health in our generations. So these are my contact, and if you want, you can leave me a message by email or by WhatsApp. Thanks, and my best to you. Bye.
working group is made up of 6 Portuguese nurses, specialists in rehabilitation nursing. The presentation follows the methodology defined for a systematic literature review: introduction, methodology, results, discussion, and conclusions. Let's start with the introduction. Self-care is a relevant concept in nursing, especially since the presentation of the self-care theory by Dorothea Oren in 1971. This nursing theory is a scientific pillar for the practice of quality nursing care. The International Council of Nursing defined self-care as the set of activities necessary for a person to maintain their life and well-being, as well as manage their individual needs and activities of daily living. Self-care is intrinsic to the person and depends on their singularity. In Portugal, there are several nursing specialties with specific skills that other nurses cannot exercise in their practice. There are specialties, for example, in pediatrics, mental health, and rehabilitation, in which nurses must take an additional specialization course, such as a master's degree. The rehabilitation nursing specialty allows the nurse to work in any cycle of life with the objective of empowering and maximizing the person's functionality, that is, promoting their functional readaptation due to disability, activity limitation, or restriction of participation in its activities. Self-care is also important for rehabilitation nursing because it emerges at a point of self-care transition, depending on the person's autonomy and freedom to make decisions regarding their health projects. The nurse specialist in rehabilitation nursing has 3 pillars in their practice: caring, empowering, and maximizing patient abilities. Health gains are assessed through indicators. Self-care is a privileged area for monitoring health gains related to nursing care. Therefore, it is essential to understand the predictive indicators of self-care that designate the prediction of a person's behavior when faced with a self-care activity. These indicators influence the person's responsibility and ability to carry out self-care actions. The identification of predictive indicators of self-care is the basis of the nursing process, as it allows efficient assessment and creation of a valid care plan. There are 2 nursing concepts that attempt to explain the usefulness of self-care indicators. Dorothea Oren presupposed the requirements and conditioning factors of self-care, but which deviate from the current context. Narasimha, Alote, and Arden emphasizes the importance of educational strategies and adaptation to transitions to promote self-care, but does not clarify the predictive indicators of self-care. From the research carried out on self-care, it was not possible to identify a structured core of predictive indicators of self-care that supports clinical decision-making. There are several studies on indicators of adherence to the therapeutic regimen in relation to pathologies such as diabetes and high blood pressure, but without identifying predictive indicators of self-care. A gap in the literature was identified, which origined the research question with a variant of PICO methodology, the PO, population outcome and phenomenon. The question is, what are the predictive indicators of self-care capacity of the adult person? The objectives were defined: identify the predictive indicators of self-care ability and identify the tools to assess self-care ability in adults. Now, I will explain the methodology of the study. A systematic literature review was carried out because this type of study allows identifying, evaluating, and synthesizing the results of several preponderant studies carried out in the health area on a specific theme. We created a specific protocol with a Prisma design in order to become scientifically solid and to minimize obstacles. Initially, we selected 6 Boolean descriptors and created several Boolean equations. We realized that they became limiting and gave rise to identical results. In this way, we choose to formulate the Boolean equation self-care and indicators because it allows us to cover all studies related to this topic. The research was carried out in September 2021. We defined the time limit as 10 years because it is a subject little study and to be able to achieve more studies. We used the EBSCOhost platform to search studies with a selection of 5 databases referring to primary studies, for example, Medic Latina and Sinal Complete. The inclusion criteria for the studies were full text available, articles with abstract, language on English, Portuguese, and Spanish, studies with adult or elderly target population, studies with an approach in the body of the text of self-care indicators or method of assessing the self-care capacity of the adult person. The exclusion criteria for the studies were full text unavailable, articles without abstract, studies with a target population of children or adolescents only. Next, I will show the main results of the research. On this diagram, I present our methodological research path through the Prisma design. Initially, we identified 620 articles, which were reduced to 41 by eliminating duplicate articles and reading the title and abstract. Subsequently, the 41 articles were full reading, excluding 32 by applying the inclusion and the exclusion criteria. There were 9 articles left that were assessed for methodological quality using the critical appraisal tools of Joanna Briggs Institute. 2 articles were eliminated because they had a rating lower than 75%, leaving 7 articles for data extraction. These are the 7 articles included in the systematic literature review. They present great variability in terms of country, year of publication, academic journal, and classification in CAT-JBI. For example, 2 articles from Norway, 1 of China, 1 of Canada, 1 of Denmark, 1 of Spain, and 1 of my country, Portugal. Subsequently, the data identified in the studies was analyzed based on the assumptions of the International Classification of Functioning, Disability and Health, as it provides a scientific basis for understanding health determinants and allows the establishment of a universal language. 3 classes of indicators were considered to facilitate understanding and systematization of the data. These classes allow the nurse to have a guide for assessing the person's self-care capacity. The classes are personal indicators, organizational indicators, and social indicators. Personal indicators are considered as intrinsic indicators to the person, while organizational and social indicators refer to extrinsic indicators. The ICF also recommends the influence of facilitator factors and barrier factors on activities. In this table, the research results were grouped by indicator, class, factor, and dimension. There are several data that can be classified into more than one indicator or dimension, which is why the classification presented by each author was chosen. The data that appears most prominently in the studies and that apparently have the greatest influence on the person's self-care capacity was highlighted with bold. In the personal indicator, several facilitator and barrier factors were identified. The facilitator factors are on dimension demographic, adults under 65 years have their own home and retirement, on psychological dimension, strong impacts of positive feelings and emotions, life satisfaction and motivation, on cognitive dimension, high level of education and health literacy, positive perception of aging, health and self-care ability, and knowledge of the disease process, and on physiological dimension, high nutritional status and restorative sleep. The barrier factors are on the demographic dimension, age over 65 years and living in residence or nursing homes. On psychological dimension, depressive symptomatology, negative perception of the disease and its consequences, feeling of abandonment, social isolation, and emotional trauma and stress. on cognitive dimension, lack of knowledge, low level of education, and mental illness. And finally, on physiological dimension, low nutritional status and comorbidity. Not many factors related to organizational and social indicators were identified. It should also be noted that no barrier factors related to these indicators. On the organizational indicator, the facilitator factors were identified: health education sessions and active aging. On the social indicator, the facilitator factors were identified: active aging, strong family support network, and testimony from people who experience similar situations. Active aging appears in these studies as an organizational and social indicator, since it is seen as an opportunity that organizations offer the elderly to maintain and develop their capabilities, providing their social inclusion and encouraging them to develop skills to live in community. A study carried out in Portugal validates this data, as the family is an agent for facilitating well-being and enhancing the capabilities of the elderly. The nurse specialist in rehabilitation nursing must consider these aspects when evaluating the person and the situation they experience. It is a specific competence of their work. The person's training process should be seen as a sharing of desires by the person and knowledge about techniques and skills by the nurse. Once the predictive indicators of the person's self-care capacity have been identified, it is possible to outline strategies to maximize the facilitator factors and remove, minimize, or overcome the identified barriers, aiming to maximize the person's functionality and develop their capabilities. The nurse considers these indicators in the evaluation phase of the nursing process. A table was also created with the main data identified about the self-care capacity assessment instruments. The studies identified in this systematic literature review do not deeply explain how each assessment instrument is applied, so the data is complemented by consulting other studies. Assessment instruments allow you to assess needs, diagnose, and predict the results of nurse care. In these studies, 4 assessment instruments were identified that enable the assessment of self-care capacity objectively: self-care ability scale for elderly, appraisal of self-care agency scale, nutritional form for the elderly, and self-care of home-dwelling elderly. Only the SACE and Hasa are validated for assessing self-care. The self-care of home-dwelling elderly requires validation, and for contextual adaptation, it is a questionnaire that is difficult to validate because it is very exhaustive and diverse. The limitations of the systematic literature review are many studies about the elderly. These aspects makes it difficult to understand the predictive indicators of self-care across the entire age range of the adult population. Many studies about self-management and the self-care on some specific diseases such as diabetes. Only 2 assessment instruments are valid to evaluate the ability of self-care on elderly: SACE and Hasa. To finish the conclusions. The main conclusions of this systematic literature review are identified apparently 3 classes of predictive indicators of self-care ability: personal, organizational, and social. Studies emphasize the relevance of personal indicators, considering that predicting self-care capacity is essential and intrinsic to the person themselves. The use of assessment instruments complements the assessment of the person, can be carried out using SACE and Hasa scales for elderly. All nurses, and above all the nurse specialist on rehabilitation nursing, will be able to use these indicators and assessment instruments, finding the balance between facilitating and barrier factors to maximize the person's functionality and self-care capacity. Through this systematic literature review, several opportunities for scientific research related to this topic were identified. Some opportunities are as follows. carrying out a broad study to validate the name of the classes of self-care predictive indicators, elaboration of studies that equally encompass all adult age groups, and that document in greater detail the items to be considered in each class of indicators, analysis of the impact of beliefs on self-care ability, validation of the self-care of home-dwelling elderly for the Portuguese population, and analysis of the impact of nurse specialists on rehabilitation nursing interventions on self-care various factors. Thank you for your comprehension. This is the references of the study. Thank you again.
Thank you very much, Doctor. Thank you. Actually, it's very interesting presentation. If there's any question for Dr. Philip. Thank you, Doctor. Thank you.
Okay, thank you.
The capacity of healthy women who wish to delay childbearing. Frozen eggs now have comparable pregnancy rates to fresh eggs in vitro fertilization, with no increase in congenital abnormalities among babies born using this technique. Success with egg freezing is more likely in younger women, ideally before the age of 38, with around 25 to 30 oocytes providing a higher chance of success. It's important to consider the cost of the procedure, including long-term storage, especially for younger women. The possibility of achieving pregnancy naturally or through standard fertility treatments should still be considered. Planned egg freezing is gaining attention in corporate environments, with several large companies covering the costs, encouraging career advancement while preserving reproductive options. Egg freezing involves controlled ovarian hyperstimulation, followed by egg retrieval, similar to standard IVF. Multiple cycles may be required as the availability of eggs decreases with age. Ongoing research explores alternatives to egg donation for women in their 40s or 50s who do not have the opportunity for planned egg freezing in their 20s or 30s. The future of egg freezing holds the potential to empower women to extend their reproductive options. With advancements in the field, we are moving toward a world where family planning can be more flexible and aligned with the aspirations of women today.
That was an excellent video. Now we'd like to introduce Dr. Timothy J. Gilte from the Arizona Center for Reproductive Endocrinology and Infertility Testing from the United States of America to give his presentation on Oocyte, cryopreservation, and updates.
Hey, thank you for having me. Can I have the next slide, please? Are you uploading my slides, please? Very good, thank you. Again, thank you for having us. We are here at the Arizona Center for Reproductive Endocrinology and Fertility in Tucson, Arizona. Can I have the next slide? No, the slides, please. Thank you. So egg freezing or oocyte cryopreservation was originally pioneered prior to sterilization procedures, either for a benign disease, surgical oophorectomy, or for cancer treatment, women undergoing surgical or chemo radiation therapy for cancer treatment. But more recently, it's been extended to be used to sort of preserve reproductive potential later in life. Can I have the next slide? It's very well known that fertility decreases dramatically with age. Peak fertility is considered to be approximately age 22 for most women. It starts to drop by 1 standard deviation by age 35 and 2 standard deviations by the age of 40. By the age of 45, it's quite difficult to achieve a pregnancy naturally, despite the ongoing ovulation. And this is primarily due to the decrease in ovarian reserve, the oocytes being depleted over time. And the oocytes that remain in the ovaries have an increased rate of aneuploidy. And this is primarily due to the delayed onset of completion of meiosis, which often results in meiotic disjunction, and which leads to many trisomies. And that's one of the main reasons why trisomy 21 is much more common with increasing age. Next slide, please. The embryology of the ovary is quite fascinating. The primordial oogonia migrate to the genital ridge beginning by 4 weeks of gestation. And they undergo replication primarily by mitosis, reaching a peak of about 6 or 7 million eggs by 20 there's a mistake there, 20 months of gestation prior to birth. At that time, they associate with mesenchymal cells and become primordial follicles. And they begin meiosis, but they are arrested in the first meiotic prophase, and they remain arrested until onset of meiosis many, many, many years later at the time of ovulation. But through this process of atresia, at birth, there's approximately 1 to 2 million eggs estimated to be stocked up in the ovaries to begin reproductive life. Next slide, please. And this process of atresia, where follicles begin to develop and become atretic, continues prior to puberty, so that by the first menstrual cycle, only 300 to 500,000 oocytes remain. And then the average age of onset of menses is approximately 12 years old in the United States. And at that time, the follicles begin recruitment in response to cyclic LH and FSH. Although many, many follicles develop each month, only one is selected through the process of selecting a dominant follicle. And at the time of ovulation, and only at the time of ovulation, following that mid-cycle LH surge, does meiosis resume. And this process goes on and on every month. And if you think about it for a moment, if you begin ovulation at age 12 and it ends at approximately age 52 at menopause, that's only 40 years that ovulation occurs, with only one egg being released each month. So approximately 480 oocytes are released in a woman's reproductive life. We begin reproductive life with 500,000 eggs, but by the time of the menopause, they're essentially all exhausted. Next slide, please. So the history, oh, I'm sorry, if you can, yeah, that's fine. So the history of oocyte cryopreservation is really in line with the history of in vitro fertilization. Many of the developments came out of each other. The first successful birth from IVF was Louise Brown, following the Nobel Prize winning work of Roberts and Steptoe. She was born in 1978. And there were many, many improvements following the first birth. Many people don't realize, but the first births from IVF did not require controlled ovarian hyperstimulation. They actually waited around following the waiting for the urine LH surge to occur, or for the natural LH surge to occur to retrieve a mature egg. So rapid improvements in controlled ovarian hyperstimulation, or COH, as well as in lab and techniques and fertilization techniques and culture techniques, led to worldwide acceptance of in vitro. And by 2012, more than 1 million babies were born worldwide. And 40 years after the birth of Louise Brown, about 8 million babies have been born. So the controlled ovarian hyperstimulation with multiple oocytes retrieved per cycle was instrumental in leading to oocyte cryopreservation. With many, many eggs retrieved in a single cycle following treatment with FSH and LH, we had to do something with the other eggs. So following fertilization, which is a very efficient process, about 70% of the eggs are fertilized, that led to supernumerary embryos. And cryopreservation of embryos was very critical in preserving more human embryos for use in subsequent cycles. Although the first mammalian embryos were first cryopreserved as early as 1947, the first successful live birth from human embryos being frozen thawed was announced in 1983 by Alan Trounson's group. Next slide, please. So the idea of freezing the unfertilized eggs was of great interest because this obviously had fewer ethical, moral, or religious, as well as legal concerns. Although the first human pregnancy from previously frozen eggs was reported in 1986, there were many, many technical problems that were associated with it. There's a huge difference in freezing a mature egg, which is arrested in the second meiotic division, as opposed to freezing human embryos, which contain cells that have completed meiosis and are contained in the nuclear contained in the nucleus. So there were many concerns due to the technical problems of spindle disruption with freezing unfertilized eggs, and problems with fertilization due to hardening of the zona. And there were only a handful of successful pregnancies that were reported by 1987. Next slide, please. So one of the main improvements in freezing was the process of vitrification. This was originally described in 1985. Historically, embryos were frozen using a slow cooling technique, using programmed biological freezers, and the advent of vitrification seemed to overcome problems that were noticed with spindle disruption. And following thousands of successful births worldwide, human oocyte cryopreservation was no longer considered experimental by 2012. Next slide, please. Next slide, please. Can I have the next slide, please? The other major development was the development of intracytoplasmic sperm injection, or ICSI. And this is a technique where a single sperm could be injected through the zona pellucida. And the first live births reported in humans were in 1992. And by 2002, extensive experience with ICSI confirmed the excellent fertilization and pregnancy rates, often higher than the standard in vitro. And this was used primarily to overcome the poor fertilization rates that were seen due to zona hardening, originally seen with freezing eggs or cryopreserving oocytes. The first live birth using cryopreserved oocytes in conjunction with ICSI was reported in 1997. Next slide, please. So, oh, please. Yeah, thank you. So with the improvements in vitrification and fertilization using ICSI, pregnancy rates using frozen eggs have become very comparable to those seen using fresh eggs that are fertilized in vitro. And the health of the babies that have been born since that time have been very closely studied and have been confirmed to have no really increase in congenital abnormalities compared with standard in vitro fertilization. And it took until 2018, it's only been 5 years now, that the American Society of Reproductive Medicine has supported the use of using previously frozen eggs to extend the woman's reproductive potential. Prior to that, it was still remained fairly controversial, fairly experimental, but it seems to have taken on great significance as a standard procedure. Next slide, please. So again, coming back to a full cycle, it's much easier to get pregnant when women are younger. And unfortunately, though, the rate of first births among women from age 25 to 39, and even from 40 to 45, continue to rise. We see an increasing trend towards later and later births. And this has primarily been attributed to several factors. One is an increasing emphasis on education. Many women are completing their education, higher degrees, before starting their families. And subsequently, later age of marriage is also a big factor. as well as increasing access to effective contraception, which gives you the opportunity to delay childbirth electively. And this obviously, delaying childbirth leads to an increased opportunity for career advancement. Next slide, please. So again, with increasing maternal age, fertility decreases dramatically beginning at age 35, and much more so by age 40 and dramatically after 45. And this again is primarily due to a decrease in oocyte quality as well as quantity. There are fewer eggs remaining in the ovaries as women age, and those eggs that are remaining tend to be poorer quality, resulting in increasing rates of chromosomal aneuploidy, which manifests either as failure to conceive or early miscarriage or birth defects, chromosomal birth defects such as Down syndrome with increasing age. Next slide, please. Next slide, please. So the idea of freezing eggs to delay childbearing or planned oocyte cryopreservation is a very attractive alternative to egg donation. Currently, a woman who is 45 and wants to conceive often has to use eggs from a younger donor to achieve a successful pregnancy. So this would allow for women to have children using their own genetic material later in life. Obviously, it's more successful when egg freezing is performed in younger women, because by the age of about 38, it's been calculated approximately 25 to 30 viable oocytes may be required to provide a reasonable chance for a single successful birth. It's not just one egg resulting in a single pregnancy. The idea of planning freezing eggs does not interfere with natural attempts at pregnancy or pregnancy with standard fertility treatment. And so it should be considered an option for most women. Next slide, please. Can I have the next slide, please? Thank you. So what are the barriers to be overcome? Should we do egg freezing for all young women? Should it be offered to everyone? Well, one of the barriers is the cost of the procedure, which in today's dollars, very analogous to a standard in vitro fertilization cycle, requires controlled ovarian hyperstimulation, use of medications to obtain the oocytes, and an outpatient procedure to actually extract the eggs, which could be safely performed in the office. There's also the potential for long-term storage. If we freeze eggs in a woman in her 20s and she doesn't plan on being pregnant until in her late 30s or 40s, there's many years of storage that have to be considered and the cost of that. In contrast to the United States and European countries, coverage for fertility is quite universal and should be extended to include the cost of oocyte freezing. In the United States, unfortunately, we have employee-based insurance, and which has led some corporations to provide or to provide the idea of coverage, and that would be beneficial to the company themselves because they would be providing insurance for fertility for their young female employees. Next slide, please. So in general, oocyte cryopreservation or egg freezing is becoming increasingly popular. I do believe that it has a place for most young women to consider when they're thinking about starting their families at an older age. Thank you very much for your attention. If you have any questions, please contact us. We'd be more than happy to provide you with more information. Thank you.
Thank you very much. Do you have any question? Can we back?
infections of central nervous system. Acute CNS infections are etiologically diverse disease, can be caused by viruses and bacteria, rare, but also by agents called Rickettsia, Mycoplasmas, parasites, and fungi, characterized by complex pathogenesis with a specific symptomatology and clinical picture. There are several types of CNS infections. Meningitis, if the meningeal membranes are primarily affected. Encephalitis, when brain parenchyma is primarily affected. Meningoencephalitis, if both structures are affected without a clear distinction. And special localized infections like abscess or MPM. Symptomatology and clinical picture include some kind of syndromes, infection syndrome with high temperature, general weakness, and malaise, meningeal syndrome with patients with headache, vomiting, positive meningeal signs, with or without impaired consciousness. And cerebrospinal fluid syndrome includes deviation in cerebrospinal fluid findings. Complication can be different, neurological, immunological, and complications of other organ systems. The diagnosis of acute CNS infections is established on the basis of the history of the disease, clinical findings, biochemical analysis of cerebrospinal fluid, and neuroimaging and neurophysiological tests. Therapeutic protocols include the use of antibiotics, antivirals, depending on the allerg or a proven causative agent, anti-edematose, and other symptomatic therapies. The prognosis of acute CNS infections can be complete recovery, recovery with residual symptoms, then more severe sequelae, neurological, neurophysiological, audiological, behavioral, and others. Electroencephalography is a neurophysiological method for registration the isoelectric potentials of the cerebral cortex. It can be prognostic and diagnostic method. The graphic record includes some kinds of wave that call alpha, beta, theta, and delta waves, and also specific graphic elements. They can be distinguished by frequency, amplitude, distribution, and distribution. Activation method we used in EEG recording are hyperventilation, intermittent photostimulation, sleep, and sleep deprivation. Pathological changes that can be found in EEG recording are focal findings, generalized changes, epileptic potentials. The aim of the research is to examine the predictive effects of EEG registration for the onset of neurological and cognitive sequelae in patients diagnosed with CNS infections. The research includes 60 responders who were treated in Clinic for Infectious Disease, Clinical Center, University of Sarajevo, Bosnia and Herzegovina, monitored in the consulting room of the clinic. Inclusion criteria, patient with clinical laboratory cerebrospinal fluid and neuroimaging manifestation of CNS infection of all age groups, with a minimum of 2 EEG findings. Exclusion criteria, patient who did not report to the consulting center patients with chronic or mental illness with encephalopathy without at least 2 EEG findings. Data from disease history and specialist opinion storage in information system of the clinic. The collected data were analyzed in relation to demographic, clinic parameters, hematological, biohumoral analysis, cerebrospinal fluid, etiological identification, comorbidity, neuroimaging diagnostic, EEG records, sequels. The research was clinical, retrospective, prospective in 4 years period. Statistical analysis, we used the package SPSS for Windows. Values of P below 0.05 were considered statistically significant. In this graph representation of certain type of CNS infections, viral or purulent. Viral infections were most common in 55%. The data are consistent with the result of other study. This is probably because viral infections are more common than bacterial ones. This graph shows sexual structure. The frequency according to the gender is statistically significant. It is which also correspond to the result of other studies. Histogram shown age structure in relation to the type of infection. In both subcategory of infections, viral or purulent, the most frequent are those up to 20 years old. For this reason, it was difficult to compare our data with other authors. Graph 3 shown relationship of clinical signs and symptoms according to the type of infections. For both subcategory, viral or purulent, the most frequent clinical signs were fever and headache, followed by confusion and positive Meningella signs. This table show of inflammatory parameters according to the type of infections, viral or purulent. For platelets in infection subcategories are not statistically significant, but for other parameters, erythrocyte segmentation, C-reactive protein, leukocyte, lymphocyte neutrophily, we show statistical significance. These results compare with other studies. This is a table showing biochemical parameters according to the type of infection. Median differences for biochemical parameter in infection subcategory are not statistically significant. For glycemia, urea, creatinine, bilirubin, and aminotransferases. Here is cerebrospinal fluid parameters according to the type of infections. For all parameters in between these subcategories, for proteins, glycemia, and chlorahia, we have statistically significant P below 0.05. This table show relationship in neuroimaging diagnostics, CT or MRI. We see that 22 respondents had both tests performed. From the 14 subjects had a normal CT, and of that number, 50% had pathological findings on MRI, while 8 subjects had pathological findings on both CT and MRI. CT is less sensitive for acute CNS infection than MRI. For this reason, MRI is the method of choice for infection for acute CNS infections. This table shows a correlation of EEG1 finding according to diagnosis. EEG1 was performed in initial stage of disease. Most subjects with meningitis had mild changes. Intermediate changes predominant in subjects with meningoencephalitis, while 66.7% of subjects with focal infection had specific changes. Other studies show that non-specific changes of mild degree are seen in patients with meningitis of any etiology, while patients with meningoencephalitis had more severe changes, more often non-specific changes of moderate to severe degree in the initial reading. This graph shows frequency of EEG changes during the acute phase of disease. Most of the responders had non-specific changes of medium degree. This is correspond with other author who examine similar research. In this graph, shown a frequency of EEG changes realized after 3 months, EEG2. 10 subjects had EEG normalized. The frequency of severe changes was reduced only for patients. Patients' frequency of specific changes increased to 10. 16.7%. So after 3 months, in some subjects, there is a normalization in the EEG findings. Changes of moderate of severe degree are in the second reading reduced in percentage, or they worsen according to specific changes in EEG, or they improve. Graph 6 shown frequency of EEG3 changes realized 6 months after the first EEG. The result shown that there were no result with non-specific changes of severe degree. The results are consistent with other studies and suggest that during the acute phase of disease, the severity of EEG abnormality correlate with prognosis. Deterioration indicates the opposite. Table 6 shown frequency of sequela according to the type of acute CNS infection. Sequels had 6 patients with purulent meningitis, 20 patients with viral meningoencephalitis, 9 patients with purulent meningoencephalitis, and 2 with focal infections. These results correlate with other studies. Results show that viral meningoencephalitis is a more severe clinical form and leaves more severe consequences in patients. Total representation of certain type of sequela according to infection subcategory, viral or purulent. Significant differences exist for sequela audiological disorder in purulent infections and loss of concentration in viral infections. The most significant sequel for both subcategories is neurophysiologically sequela, like epilepsy, followed by headache and behavioral disorder. Similar results we have found in other study in short-term follow-up, 6 months to 1 year, but long-term follow-up with more severe sequela is also evident in the literature. This graph shows relationship to certain type of sequela to EEG1 findings. Headache have moderate EEG changes dominate. Loss of concentration dominate moderate EEG changes also. Epilepsy had specific changes both and severe, and behavioral disorder had moderate changes dominant. The result correlate with other studies. Relationship of certain type of sequela according to the EEG3 findings. Headache, mild changes dominate, but a significant number of these have normalized. Loss of concentration, both mild changes and normal findings. Epilepsy, specific changes dominate, and behavioral disorder, a significant share with specific changes, but also normalization of findings. Many studies in the last 10 years have shown the importance of monitoring EEG records during the initial phase of the disease and later, during the post-hospital period in terms of predicting neurological sequelae. Subjects who have severe EEG changes during the acute phase of the disease in a large percentage develop sequela that require serious care and monitoring. This table shows frequency of sequela at follow-up period. Initial after 3 months and after 6 months. Headache more frequent after 3 months and after 6 months evident recovery. Loss of concentration and motor sensor deficit follow continued recovery in follow-up period. Epilepsy present during the follow-up period 6 months. Audiological disorder present during 6 months follow-up, and behavioral disorder are in discrete recovery only after 3 months. A large study by Knie and other author that examined the sequela of West Nile encephalitis show a prolonged convalescence period with residual physical, cognitive, and functional disorder 20 months after acute infection. But these are still as isolated studies. In conclusion, EEG recording is a good predictor of neurological status during and after acute CNS infection. The clinical status at admission, primarily neurological, had a statistically significant association with diagnosis, meningitis, and meningoencephalitis, but it was not determined between the subcategories viral or purulent infections. EEG has a good predictive value in determining the neurological outcome of acute CNS infections. The severity of the abnormality in the initial EEG recording correlates with the prognosis. An improvement in the EEG recording is an indicator of a good prognosis. The prevalence of sequela after discharge in the entire study sample was 62. Epilepsy was the most evident, followed by headache and behavioral disorders. Significant statistical significance of purulent infections was found for the sequel audiological disorders and loss of concentration for viral infections. A normal EEG record or one with mild, moderate changes leads to a normal neurological outcome. The convalescence period for acute CNS infections was usually up to 3 months. Thank you.
Thank you very much, Ms. Bilma, for this wonderful presentation. If you have any question for Ms. Bilma, you can ask now. Thank you, Ms. Bilma. Thank you very much.
Thank
so
you.
We can move now to the other topic by Ms. Kat.
To chemical, biological, musculoskeletal, physical, and psychosocial risk. This last dimension has gained significant prominence since the pandemic, given its potential to negatively impact the resilience of healthcare systems and patient safety. Thus, developing systematic strategies to enhance working conditions is crucial for establishing a secure environment. This involves identifying and assessing risk to implement interventions that promote both well-being and workplace safety. This study arose because the Chilean Occupational Safety Institute issued a call for a tender with the aim to construct and validate an assessment instrument for occupational hazards among nursing personnel working in hospitals. The method, a methodological study with a mixed qualitative and quantitative design, was conducted in 4 hospitals located in Valparaiso region, Chile, between January 2021 and September 2022. The research was carried out during the pandemic, which implied great challenges to overcome. The study had the ethical approvals by the Chilean Health Authority. The research was conducted in 3 phases: integrative literature review, qualitative study, and quantitative study. The integrative literature review regarding occupational risk and risk assessment tools for nursing staff was carried out in different databases to answer the following guiding question: what evidence is available in the literature regarding the occupational risk of nursing personnel working in hospitals and the tools to assess this risk? Spanish and English DexMed keywords were used. Primary studies, systematics review, integrative review, and meta-analysis of the last 15 years were searched, combining different keywords to ensure comprehensive results. The integrative literature review identified 11 categories and 26 subcategories of hazards, forming the basis for guiding the qualitative stage. Stress and emotional exhaustion, risk associated with the individual and their relationship with the organizational environment, mental workload, shift work, violence in the workplace, relationship styles of health personnel or teamwork, musculoskeletal risk, biological risk, chemical risk, physical risk, and double presence. Next, the qualitative study was carried out between January and September 2021. Due to the COVID pandemic, the work modality was adjusted, conducting part of the activities remotely using the Zoom platform. The objectives of this stage were to define the theoretical and operational concept of the risk of workers in the nursing team in hospitals, to determine the importance of the risk defined according to the workers, to understand the connotations and symbolisms of the risk and what space they affect, psychological, emotional, relational, physical, functional, security, work, institutional, authority, etc. To know the biopsychosocial impact to exposure to the identified risk, to know institutional risk management strategies. The participants included nursing managers, supervisory nurses, clinical nurses, administrative nurses, nursing technicians, occupational risk officers, and occupational psychologists. Data collected involved focus group, individual interviews, and non-participant observation of the daily activities of nursing and nursing technicians. Guidelines were developed for conducting interviews and focus group. Both focus group and individual interviews were recorded in audio and video files. Non-participant observation involved accompanying daily tasks and observing the working condition in 30 clinical units. Field notes were taken using a field notebook, which included the narrative and the meta-narrative of the observations. The data obtained from the discourses were initially analyzed using the predetermined categories and subcategories. The textbook citations were grouped into first and second level categories and subcategories. Content from each code was analyzed, comparing it with the rest and identifying the elements in common, which permit the creation of additional subcategories to those previously defined. During a second analysis stage, Excel coding was carried out, giving rise to the second level categories. 128 items were constructed. A total of 1,355 textual citations were analyzed. 11 categories of risk were identified. The most frequently mentioned categories of occupational risk by the participant in the discerning order were stress and emotional exhaustion, risk associated to the individual and their relationship with the organization environment, mental workload, and relationship styles of the healthcare personnel and work teams, representing the 75% of the citations. It was observed that while risk categories are common among nurses and nursing technicians, they affect them differently, determining their way of experiencing and evaluating them. The 11 categories of risk gave rise to 25 first level subcategories and 98 second level subcategories. The process of formulating questions for each dimension was carried out considering both first and second level subcategories for each dimension. For example, for the dimension stress and emotional exhaustion, the first level subcategory was stress and emotional exhaustion due to the work overload. The second level subcategory was strenuous work days, many patients, procedures, meetings, problems to solve. And the item of the scale was my work days are exhausting. taking care of many patients, or my administrative work is excessive. The instrument with 128 items proposed were subjected to content validity by the judgment of professional experts. The validity assessment was performed through criteria of relevance, conceptual clarity, and writing, using the methodology proposed by Hernandez Nieto. Next, a pilot study was conducted. This pilot study revealed the impossibility of generating a common instrument for all types of nursing job positions, although the requirement of the Occupational Safety Institute was to build one instrument. Therefore, three possible groups of questions were grouped. The first with common items for all the nurses and nursing positions. The second with common items to all the nursing positions that take care of patients. And the third with common items to nurses and nursing technicians who don't take care directly of patients. However, the combination of the 128 items can give rise to 17 instruments. Due to the magnitude and technical feasibility of validating 17 instruments, it was decided to subject the three instruments with common items to an initial study of validity and reliability, leaving for a later stage the validation of the 17 assessment tools foreseen. Next stage was the quantitative study, the validity and reliability. The research design corresponding to a quantitative study with a descriptive cross-sectional scope carried out between December 2021 and April 2022. For each group of interest, the corresponding instrument for the job position and unit in which each nurse and nursing technician worked was used. This included a variable number of questions on a 5-point Likert scale, ranging from 1 strongly agree to 5 strongly agree. For data analysis, we used the software Stata version 17. Descriptive statistics were calculated, and the internal consistency of the items and categories was studied using alpha Cronbach coefficient. Exploratory factor analysis using the principal axis extraction method with Marimax rotation was used for the validity study. Additionally, as a preliminary assessment of the goodness of fit of the factor analysis, the standard goodness of fit indicator were calculated, excluding categories with 1 and 2 items. The variability in the number of questions resulted in an imbalance in the structure of the risk categories, which led to the need to standardize a score to generate a single risk assessment indicator that will make the instrument comparable regardless of the number of questions they included. Taking into account the number of items per dimension in each instrument, the minimum and maximum risk scores were established. Then the scores were centered in relation to the minimum score as well as standardized according to the maximum score. The latter correspond to the overall occupational risk index and ranges from 0 to 100 points. We also established 3 risk levels: low risk, medium risk, and high risk. Finally, the score obtained by the participants in each of the 11 risk categories were standardizing, resulting in a specific occupational risk index. The result of the quantitative stage were the content validity analysis coefficient was 0.97. The pilot study was satisfactory, and then we proceeded to validate 3 instruments with common items in 503 participants. The construct validity study revealed a high internal consistency of the 3 questionnaires. The common batch alpha ranged from 0.88 to 0.93. Exploratory factor analysis identified between 8 and 11 dimensions. However, the goodness of fit indicators were not satisfactory. Let's review the result of the application of the questionnaire with 52 common items and 8 risk dimensions for all job positions of nurses and nursing technicians. The items with highest average were my responsibility and commitment when job was established. There is a shortage of healthcare personnel. The tasks I perform are highly demanding, and my work days are exhausting. And the items with lowest average were, I am aware that taking care of myself is important. Communication with my direct management is expeditious. My supervisor exhibits good leadership, and I have experienced verbal aggression for a member of my work team. The overall risk index measured for the 5 categories of nursing staff was observed at middle level, with a little variability in the scores standing out. Statistically significant differences was found between the overall risk index of managers, clinical nurses, administrative nurses, and nursing technicians, with a p-value 0.0409. In the specific occupational risk index, the results were with the highest average for stress, the supervisory nurses with 57.9 points. For risk associated with the individual and the relationship with the organization environment, the highest score were for the nursing technicians with 54.7 points, and for relationship styles, the nursing technician with 41.7 points, and for mental workload, supervisor nurses with 54 points. Significant differences were detected between the scores obtained by each category in the dimension of stress and emotional exhaustion, physical risk, and risk associated with the relationship styles. Conclusions. The instruments demonstrate good parameters of content validity and reliability with the needs to enhance their construct validity. Perception of hazard varies depending on the role played by each professional. There are significant challenges for the occupational health of this professional group given the nature of nursing work, the characteristic of the professional profile, and the exposure to hazards throughout much their working life. There is a need to expand existing knowledge for the generation of effective strategies to improve well-being, prevent occupational disease, and work-related accidents. This is the study limitations. Thank you. This is my presentation.
Thank you very
I
much.
want to share for you some pictures from Chile. Thank you very much for the attention.
Thank you, Dr. Katia, for this wonderful presentation.
A lot of view because we always see for another things like colon cancer that are after this amputation rate and mortality secondary for the amputation in diabetic patients, and ischemic ulcer and peripheral arterial disease that is after that and is surrounding the context of the diabetic foot amputation. When we have patients with amputated patients, the survival in 5 years mortality is like 40%, that we have to take very close because we are provoking mortality in this patient when we amputate any part. Principally, we are talking about the foot, but it's a very important thing because if we are preventing or salvage, no giving all the amputated patients, we are changing the mortality to an 80% of salvage with a very significant statistical that we are always think to make the salvage of the limb. This is a thing that we always talk in a good articles, and holistic management is the thing that we have to do. In my hospital or my private practice, we can't do that because we don't have all these persons that want to take this patient that is very difficult, that is very chronic, that is very hard to tell, to give a mindset, to give all the things to make it right, to salvage these things. First, we have a person that give all the primary care. In my place, we have a nurse. We always talk each other. We always see each other. We are very close with the patients. We don't have a vascular specialist. Is the first step that I think that we have to do, because we have to evaluate. This is the keystone of all the problems, but we don't have this specialist in my place. Orthopedic, we don't have it. Not all the physicians want to do this job. The nervous, we have to do some surgeries to allow that the nervous system become better or don't continue to the damage. The infections is very important because all of these patients are with infection if we are talking about the wound and all the other. In my practice, we only have these physicians that are working with me, and all the other things I am doing that. And this is the most problematic thing here in a country that we don't have all the good thing in the holistic management. What are we doing? Because we have to stay in close with the thing that we have to salvage the extremity, because we have a mortality rate very high. In the holistic management here in Mexico, we have the advanced course that we have the dressings, the negative pressure systems, but in Mexico we have a lot of physicians that only do that. This is why we have a chronic patient, or we think that we are not working very well, or is very unsuccessful, the diabetic patient. But we want we have the other persons that only do surgery, and we want to make a balance there in the management of the persons that had a wound in diabetic. Preventive is the keystone. We make a lot of nervous release that we can prevent all the deformities, talking about Charcot or problems with the sensitive that can't prevent any trauma. We make tendon enlargement that we can make a better walk. Always looking for limb salvage. We make bypass when we go with ischemia, distal ischemia. I don't do any endovascular. That is the first option, but we don't have that. I talk to you. And when we have any free flap, we can do this type of things. We are microanastomosis, a very tiny anastomosis that can give the patient a one option. Here we start with the very tiny problems that we can do. A skin graft is a circumferential a person that we don't have that he never take any of their pills, is a cirrhotic patient, is cirrhotic with after alcohol taking, and we can put a skin graft to salvage this skin. We have another patient that I refer for another physicians that make amputation, and we don't have that vascular thing, but we always think that to explore the vessels and to preserve always, if we can, we have a better biomechanic component if we make all the fingers out, and we could have this, and the survival rate will be very good. Like you see, we have a lot of these patients. We have a lot of persons that have a complication after another surgery. We have this portion of Achilles tendon that after that the patient have a rupture when she was walking, because we always put a pressure garment to allow that the drainage of the limb become good. We have the rupture and the fracture of the person. Now we are always seeking with a culture, with all the laboratory tests, and when we have a reactive protein below of 10, we always do the close. Now we are doing 2 flaps with a tendon flaps that we reconstruct the Achilles tendon, and another flap to put over the tendon. And we are in diabetic patient, we are seeing that we have a good result, but it's very chronic. It's very chronic. Okay. We have another patient that lost with an infection of the plantar skin with exposure of calcaneum. We are doing free flaps. This is our free flaps for the thigh, LAT, and we are doing always sensitive if the patient have sensibility or function of the nerves in this area, and seeking that the patient can return to walking, okay? And always seeking that he can wear a shoe with a good cover. We have another patient that is very common with the orthopedic, is a fracture. It was a close fracture of tibia and fibula, and the wounds are not going well after that. It's a female of 73 years. 1 month we have this patient, and we are doing all the things. We remove all the hardware. We only take the hardware in the patient with 2 weeks because we had to remove and we put a nail, intramedullary nail, and we always look to look the flaps, locally flaps. She only have the vestibular artery, and we are doing all with the vestibular artery perforators to cover the area. It's not always good. We have the exposure of the tibia, but we are very obsessed with preservation of this, and we work very hard removing this, making another flap, conservative treatment, that balance between conservative treatment and surgical, and these are the results after 3 months. And we are looking for that, no? A very bad glucose test, always for the patient, no nutritional assessment, but we are doing that. We are doing perforated flaps too. When we have a patient that have to cover in the foot, we can do that. We are good results, and we can do in the patients with diabetic. We had another patient that had this. They come with us. They suffer amputations for 3 fingers and still have the infection and the necrosis of the other finger, and he have he's a renal patient. He had a transplant, but now is not working, and we are always thinking about to salvage this, and we did a sympathectomy to improve this vascular, and we have a pinch hand that he can do a lot of things. It's not a very dramatic result, but he's still having her hand and doing well. Another cirrhotic patient that come with us with this necrotic thing in the nose, and we do some flap, we do some skin flap, and we have this. We are doing a lot of salvage things, working with the very hard because we don't have all the holistic management. Thank you.
Thank you very much, Ms. Jesus, for this presentation. Actually, it's hard to see this picture. It's very difficult for us to see this picture, but we hope all the attendees take the benefit from this presentation. If there's any question for Ms. Jesus, you can ask now.
As the population ages, cataracts are becoming an increasingly common pathology. This can be seen in the growing number of cataract surgeries, which rose from 14,226 in 1993 to 146,958 in 2015, due to Direção-Geral da Saúde. Cataracts are a chronic, irreversible disease that results in the progressive loss of transparency in the lens of the eye, which can progress from mild loss of vision to blindness. Ambulatory surgery aims to increase client satisfaction and provide a better response in terms of community health by reducing the number of hospitalized clients, reducing the rate of healthcare-associated infections, reducing waiting lists, reducing hospital costs, and freeing up beds for hospital admissions required for other pathologies due to Bologna. The preoperative nursing consultation is the time to facilitate the client's preparation for surgery, creating a relationship of empathy and help with the client and carer. It allows us to start promoting the potential for autonomy with a focus on preparing for discharge. According to Espanol, satisfaction can be understood as the result of a user's assessment of the degree to which their values, needs, preferences, and expectations have been realized. It's an important indicator of health quality. The objectives of the study are to identify client satisfaction with the outpatient cataract surgery nursing consultation and recognize the usefulness of the cataract surgery nursing consultation for the client. In terms of methodology, this is a quantitative, descriptive, and exploratory study conducted in a hospital in central Portugal. We use a highly structured interview via telephone using a form Likert scale from 0 to 4. The sample is made up of clients who had a preoperative nursing consultation for cataract surgery and who had undergone this intervention at this institution between the 1st of January and the 31st of December 2019. The study sample is non-probabilistic and of convenience. Initial sample was 783 clients who had a preoperative nursing consultation. The final sample, 348 clients, excluding clients who died, duplicates, operated on both eyes, uncontactable, or who refused to take part in the study. Data analysis was made with statistical package for the social sciences version 22. Data confidentiality and voluntary participation with the possibility of withdrawing from the study without any prejudice were guaranteed. And we obtained a favorable opinion from the Ethicals Committee. The results of the study are presented below. The average age is 73.74. The youngest age was 44 and the oldest was 98. With regard to the question fasting or medication, the need for a companion for the surgery and the need for a companion carer for the first 24 hours, the average number of responses was 3.72, which means they considered the information given in the preoperative nursing consultation to be extremely relevant. This assessment is important because outpatient surgery requires compliance with mandatory criteria. Failure to fulfill these criteria means that the surgery is postponed with all the costs and losses for both the client and the institution. Regarding the question, do you consider the information given in this consultation regarding the preoperative and postoperative phases to be relevant? The average is 3.73, which means that the information given in this consultation is extremely pertinent, both pre- and post-operatively, to ensure the success of the surgery and contribute to client satisfaction. With regard to the question, were you informed about post-surgical care, namely not exerting yourself for a week, placing the drops, disinfecting your hands? Do you think that your doubts were answered? Do you think that the video was informative and enlightened you? And do you think that the information leaflet was useful and enlightening? Knowing that the information is transmitted in the nursing consultation orally, through an audiovisual film, and by handing out a pamphlet explaining the important points to bear in mind before surgery, an average of 3.75 referred to information on post-surgical care is extremely enlightening. Action. With regards to the question, was the preoperative nursing consultation enlightening so that the information coincided with what happened after the surgery, contributed to reducing your worries about the surgery, and contributed to making you feel more secure? There was an average response of 3.69, which means that the preoperative nursing consultation was extremely informative. Guerreiro mentions that statistical studies carried out by Melo show that clients who are informed about their clinical situation have a higher level of satisfaction than clients who are not informed. When asked how they rate their satisfaction with the consultation and how they rate the quality of the service provided, the average response was 3.78, which means that the preoperative nursing consultation was extremely informative. According to Timoteo, as satisfaction is an important indicator of the quality of services, it should therefore be used as a guide for nursing care, since there is a proportional relationship between customer satisfaction and the assessment of the quality of care provided. We can conclude that customers have very high satisfaction ratings. We found an overall average on the questions of 3.73 out of a maximum of 4. This translates into a satisfaction level of 93.73%. In conclusion, as mentioned above, the preoperative nursing consultation is a fundamental contribution that guarantees efficiency and safety in outpatient cataract surgery care. All information passed on to the client caregiver must be adapted to their ability to understand, enabling them to assimilate all the information passed on. Information for people undergoing cataract surgery is one of the aspects that most concerns nurses in outpatient surgery. All the information provided to prepare the client and their families is very important. Explaining the technical procedures as well as the entire course of action to be taken on the day of the client's surgery aims to prepare them as well as possible for the surgical experience, providing success for the satisfaction of the entire treatment. The information provided should be simple, if possible, using audiovisual aids, conveying reassurance and involving the client in the whole process. As is well known, effective information improves communication, provides satisfaction, and reduces anxiety related to the experience of surgery. In this way, we contribute to a continuous increase in the level of the satisfaction as the ultimate goal. We recognize that customer satisfaction with nursing care is an essential indicator of the quality of the care provided. Our study gives us the opportunity to find out what our customers think about the quality of our services and their satisfaction. By continuing this service, we aim to optimize resources by promoting customer satisfaction and reduce the effects of hospitalization. The preoperative consultation is part of our profession from a perspective of quality care with the continuous goal of efficiency, which materializes as a contribution to enriching our daily clinical practice, reflecting the excellence of knowing how to care. As implications for practice and future developments, this study allows us to state that it is extremely important for institutions to encourage and increase preoperative nursing consultations in outpatient cataract surgery and to reflect on the decisive importance of providing nursing care associated with satisfaction and quality, promoting excellent care geared towards the needs of clients. It is necessary to develop scientific knowledge in this area, promoting gains for the client and the institution. This study could encourage comparative satisfaction studies between clients undergoing cataract surgery with and without a preoperative nursing consultation. Thank you for your attention and availability. Here is the QR code to access the bibliographical references. At the bottom is our email address in case you want to contact us with any questions related to this study. As a curiosity, the image in the background is an illustration of the city of Porto, which is one of Portugal's favorite tourist spots should you wish to visit in the future. We are now available to answer any questions you may have.
In the clinical practice guideline, you will find in detail the general recommendation for the provisions of medical care to trans minors, a section of history taking, physical examinations, and initial tests, the treatment that is used, that is, medication used, the effects of therapy and its monitoring of both puberty suppression treatment and the gender-affirming hormone therapy in trans female adolescents, in trans male adolescents, and non-binary individuals. There is also a section on recommendation for potential fertility perseveration. Gender identity, gender expression, biological sex, and sexual orientations are different, but interrelated terms. A trans man may be on testosterone treatment, come wearing makeup to the consultation, or be homosexual because he is attracted to other men. Gender expression, that is, clothing, testes, etc., it does not define the gender identity that responds to who I am. Sometimes social transition is required for one's own self-identification of gender identity. So, a person assigned female at birth may think they is a man and make a social transition, but soon realize that this is a non-binary person. Gender variance may manifest in childhood with non-normative gender expressions, which does not mean that the child has a gender identity, identifying as a male, female, or non-binary, different from the sex assigned at birth. The development of gender identity is a multifactorial process that involves self-identification. The individual may be aware of gender identity from an early age. The gender identity, gender expressions, and needs of the minor must not be invalidated, but it is also important not to anticipate them or project the path the individual should take. There needs to be a change in social perception to allow the free expression of the fully diversity spectrum and free personality development, promoting safe spaces that allow exploring identity and diverse expressions. Parents can experience it as a grieving process when their child comes out as a transgender. Sometimes there are significant disagreements that lead to legal actions. We need to recommend support, not invalidate the gender expression or gender identity of the person. Respect the times and the way the person wants to be coming out as a trans person. Native Americans considered 5 different gender identities that were respected. If in the society in which we live there was no stigma regarding trans people, and they could live expressing their genders regardless of their appearance, it is possible that they would not resort to hormonal or surgical treatments. trans or non-binary people may have different needs. Pubertal blockage or not. Gender-affirming hormonal treatment. Partial virilization or minimal interventions with or without induction of amenorrhea, or partial feminization. You may want to stop medication because you already have the desired appearance. It may or may not require surgery, phalloplasty, mastectomy, vaginoplasty, etc. Supporting any progress in body self-acceptance, favoring the least possible medicalization to facilitate emotional well-being, and providing respectful spaces for reflection. Endocrinology treatment decreases stigmatization, bullying, anxiety, phobias, self-medication, poor school performance, risk behaviors, self-harm, suicidal ideation, or eating disorders. Trans masculine adolescents stop eating because they do not want puberty to progress, or they want breast volume to decrease, or to stop having menstrual cycles. Informed consent should be signed by the legal guardians of the minor. Multidisciplinary work is carried out, including psychological support by expert personnel. This should not result in a delay in the start of hormonal therapy for transgender minors. It should not be for diagnostic purpose, and no evaluation should be conducted by a third party to determine their identity. Not all transgender individuals will require such support, but for most, it will be essential due to the challenges they face in society. In the medical record, gender identity and sex assigned at birth should be noted, as well as the preferred name and pronouns, avoiding assumptions based on physical appearance, preventing misgendering, refraining from asking about the dead name, and when in doubt, using last names. Inquire about family and social support, social or emotional problems, difficulty with self-acceptance or rejection by the environment, desire for physical changes, expectations, and knowledge about therapeutic possibilities. Focus on the clinical approach based on individual needs. Inquire about fertility desire. Inform the possibility of fertility perseveration before treatment, and if treatment has started, the potential for fertility perseveration after discontinuing treatment. Ask about lifestyles. We must remember that cannabis may hinder the action of testosterone. Administer of the vaccine against papillomavirus, which is recommended in every trans person under 26 years old. Ask for relevant family and personal medical history. Initial blood tests include complete blood counts, comprehensive metabolic panels including renal, liver, and electrolyte panels, blood glucose, and lipid profile, total cholesterol, luteinizing hormones, high-density lipoprotein, and triglycerides. 25-hydroxyvitamin D3, follicle-stimulating hormone, luteinizing hormone, estradiol, testosterone, thyroid-stimulating hormone, and free thyroxine. The bone age is requested if it is appropriate, depending on the evaluation and as deemed necessary. The bone density scan with dual energy X-ray absorptiometry if pubertal suppression therapy is expected to last longer than 1 year, or for the same indications that apply to the general population, such as anorexia nervosa. The karyotype indicates of suspect disorder of sexual development or incomplete puberty or in trans boys that did not experience menarche before puberty blocking, as it may mask possible warning sign of disorder of sexual development. Depending on the evaluation, the baseline adrenal androgen profile is requested. In trans girls, rule out hypercoagulability in the case of personal history or family history in first degree relative of thrombosis. Regarding puberty blockers, if there is distress, they can be used without delaying treatment to prevent undesired physical changes. Monthly or quaternary gonadotropin-releasing hormone analogs are the preferred choice. An alternative for postpubertal transgender women include spironolactone with careful monitoring of electrolytes and cyproterone acetate. There are a low risk of meningiomas, which increases with cumulative doses and is more effective if reducing erections is desired. A daily dose of 10 mg is sufficient. Other options include Dionogest and nomogestrol. Progestins can be used to induce amenorrhea in transgender men. The effects of pubertal suppression therapy. There are contradictory studies regarding the recovery of bone mineral density, BMD, with sex hormones treatment after pubertal suppression treatment, although some studies suggest that the observed decrease in bone mineral density, especially in trans women, is more lifestyle dependent. Due to hormone deprivation, menopausal type signs, neurovegetative symptoms, fatigue, mood swings may appear in the first month of treatment in trans adolescents with Tanner stage 4 or 5 puberty. If pubertal blocks is performed at early Tanner stages, when required in femme trans adolescents, the preputial tissue may be insufficient to be used for a later inversion vaginoplasty, which is the technique of choice. In these cases, a colovaginoplasty or a graft-using vaginoplasty, which are more complex surgical procedures, can be performed. Many female trans adolescents are mostly concerned or distressed by voice changes or the appearance of facial hair changes that occur in Tanner stage 4, which is why they can tolerate a Tanner stage 3. If it does not cause discomfort, a greater development of the genitalia compared to if it were blocked in Tanner 2 stages may or may not be of interest to the trans woman in her future relation, or, if she wants a vaginoplasty, a greater penile length will be useful to the surgeon. This is a reason why the start of the pubertal block must be individualized, avoiding the appearance of undesired physical changes, optimizing the emotional well-being, and at the same time minimizing the possible side effects. Pubertal suppression treatment can stop the maturation of germ cells, thus affecting fertility, but these effects are reversible if treatment is stopped even if administered for a long period of time. In gender-affirming hormone therapy, there is no evidence of the optimal age to start. World Professional Association for Transgender Health suggests around 14 years old. Delaying hormone therapy for those who desire physical changes is a strong predictor of psychopathology and can pose risk to bone health in puberty if suppressed for many years without starting gender-affirming hormone therapy. I'm going to show you some tables from the clinical guide. For example, this is a summary table of complementary examinations to be performed when monitoring treatment in trans adolescents. Checks are carried out every 3 months in the first year, in the second year 6 monthly, and then yearly. I would like to highlight a table of side effects of gender-affirming hormone therapy in trans female adolescents or non-binary individuals assigned male at birth, which include headaches with worsened migraines, mood swings, fatigue, especially with cyproterone acetate, anecdotal report of thrombosis, hyperprolactinemia, and liver dysfunction. For trans male adolescents on gonadotropin-releasing hormone analogs, they should not be discontinued until reaching adult dose of testosterone. Pubertal blockade in advanced Tanner stages is not necessary unless there is a desire for rapid menstruation suppression. But it's important to note that self-harming behaviors and depressive symptoms can peak during menstrual bleeding. Inducing amenorrhea is achieved through proper hypothalamus-pituitary gonadal axis blockade, proestrogens, oral contraceptives if estrogen is tolerated, and in adults, endometrial ablation or surgery. This is another table. I would like to mention list common side effects in trans male adolescents or non-binary individuals assigned female at birth, including acne, polycythemia, dyslipidemia, androgenetic alopecia, mood changes, and local reactions. There are also partial estrogenization or virilization options, which are often requested by non-binary individuals. But such demands can apply to transgender men or women too. Intervention should be individualized and flexible based on needs and may involve combining different treatments, considering the efficacy and safety of the drugs used. There are multiple protocols outlined in the guideline clinical, using lower doses of estrogen or testosterone, inducing or not amenorrhea, etc. In conclusion, clinicians must provide individualized and adaptable care, including hormone therapy, tailored to the extent possible to the needs of the individual, and beyond the dichotomous goals of the traditional binary gender model. The care of trans children and youth required a multidisciplinary approach and delivery by professionals specialized in gender identity, capable of adapting to the needs of the patient and embracing the diversity of trans individuals in the perception of the body, gender identity, or gender expressions. Thank you. My email is endocrinera.villanova@gmail.com.
Thank you very much for this wonderful presentation and wonderful videos. And we will hope to continue other videos for the speaker tomorrow. Finally, we have finished day one agenda of nursing 2023. My heartfelt thanks to all the speakers and attendees who made this event a success with their eminence and presence. We hope to meet you all tomorrow.